my SB 1058 and Senator Dean Flores' SB 158, hospitals are now required to, I'll just mention three key pieces, to implement infection surveillance and prevention procedures recommended by the CDC, screen hospital patients for the superbug staph infection MRSA, and third, report infection rates for the most common types of infections to the CDC to enable the department, DPH, to access the information and begin posting it for the public starting in January 2011. So let's talk about some of these. Reporting. On the positive side, 85% of California's 400 hospitals are now reporting their rates of hospital-acquired infections. And those 400, the 85% of those 400 hospitals ought to feel really good about that, and I commend them. But that still leaves as many as 15% that are not reporting this information. That's roughly 60 hospitals that are not reporting, despite the fact that the requirement for them to report has been on the books since 2008. So that's 60 hospitals for which information may not be posted on the DPH website starting in January 2011. And that means potentially hundreds of patients who may not get the information they need to select a safe hospital. In addition, I have real concerns whether the department is using its authority to clarify and define the infection reporting requirements to ensure that hospitals report this information consistently and in a way that makes comparisons among hospitals possible. And certainly with technology today, that part should be easy to do. Second, the routine inspections of hospitals. On the positive side, DPH is finally beginning to regularly inspect hospitals every 3 years for their compliance with infection control requirements. And that's really good. However, the legislation that requires DPH to do these inspections has been law since 2006, meaning it's close to 4 years for DPH. It's taken close to 4 years for DPH to begin to do this. Very few hospitals have been cited for violations of these requirements, and patients' health and lives have been jeopardized as a result. The third piece, infection control regulations still pending after 4 years. Also, on the negative side of the ledger, SB 739 required the department to promulgate regulations based on the most current CDC infection prevention guidelines that hospitals must follow. I'm concerned that the department is just starting the process to adopt these regulations 4 years after the enactment of SB 739. In the meantime, it has been recommending that hospitals comply with the CDC guidelines, which clearly fall short of what the legislature intended. The fourth piece, enforcement. And the bottom line here is that proactive identification is not yet happening. Finally, it troubles me that the department is not being more proactive in identifying hospitals with poor records for infection control. While inspecting hospitals on a routine basis is helpful, most hospitals are only inspected once every 3 years or in response to complaints. I'd like to see the department explore working with the Office of Statewide Health Planning and Development, OSHPD, to improve the discharge data that hospitals are required to report to OSHPD. So there's some information there that is still really not getting out to the public. I think there is great promise in DPH examining in real time the data hospitals report to OSHPD on their patients and what they're treated for. Once we have really good data coming in, DPH should be able to identify hospitals that seem to have high numbers of infection rates. DPH may discover, as an example, that a particular hospital is reporting abnormally high numbers of patients being treated for infections during their stay, which it could use to focus its enforcement efforts. It's almost 2011. Mass amounts of healthcare data are being transferred electronically to various departments in state government. But the state's process for utilizing that data is stuck back in the 1970s. We have to get out of the silo mentality, bring the data together, and those who use and analyze that data so that we can have a complete picture of how a hospital is doing. I mentioned earlier there were three key components to the hearing. That first one being hospital-acquired infections. Now we're going to go on to the second one, which is reducing medical errors. We'll also be looking today at the Department's implementation of my legislation from 2006, SB 1312, which requires hospitals to report 28 specific types of medical errors, which are known as the never events or the adverse events, to report them to DPH. And the same legislation required DPH to investigate them within established and very specified timeframes. These are things that should never occur, the never 28, such as conducting surgery on the wrong patient or the wrong body part, or leaving a foreign object in a patient after surgery, or conducting surgery on a patient who is not fully under anesthesia, are medication errors. And I and my staff know of specific examples in all of those areas. Let's take the investigations piece first. My sense is that the department is doing a better job on reducing medical errors in comparison to infection control, but it could be doing even better. To its credit, and I commend Ms. Billingsley a lot, the department has investigated more than 1,000 reports of adverse events and is handling most of them within the required timelines. The department also has issued administrative penalties for 85 adverse events using the authority provided under two other bills I authored, SB 1301 and SB 541, the latter of which established fines of up to $100,000. Let's take the second piece of the medical errors, the enforcement. What troubles me is the department is aware that some hospitals are either not reporting or are under-reporting adverse events, but it is not taking the steps to proactively identify these hospitals. Rather than relying on hospitals self-reporting directly to it, DPH could use the data hospitals report to OSHPD to identify hospitals that appear to have high numbers of adverse events that are not being reported, and to target those hospitals for infection. Here, too, we need to take advantage of modern technology and utilize the OSHPD data to get the complete picture of a hospital. I'd like to understand why the department is not more actively using this approach to identify hospitals that are underreporting the number of adverse events. And now I'd like to speak about the third main part we've done. Two of the pieces now, and we'll do the third, which is the hospital nurse-to-patient ratios. The last issue that we'll be looking at today is the department's implementation of Senator Sheila Kuehl's legislation from 1999, which requires hospitals to meet specific nurse-to-patient ratios by type of hospital unit. These ratios range from 1 nurse to 1 patient in some units, such as the operating room, to 1 nurse to 5 patients in general medical/surgical units. As with other public safety measures, I would have to say that the department's enforcement record is mixed. Let's talk about the regular inspections first. While DPH inspects some hospitals for their compliance with the staffing ratios, it doesn't do so on a regular basis, and instead only inspects in response to complaints. That worries me because, according to the department's data, it has issued over 450 citations to hospitals for violations of these requirements, and that's just in response to the complaints it receives. It's not unreasonable to think that the number of unreported violations might be much higher. That's why I don't understand why we are not incorporating nurse staffing ratios into the routine 3-year inspection of hospitals. And I wonder what the barrier is to doing that. I really would like to understand that. Okay, so now we talked about the regular inspections. Now we're going to talk about follow-up inspections. So it's one thing once every 3 years to be doing these inspections, and then to inspect in response to the complaints it receives. But now we need to look at what happens on follow-up. It's not clear that hospitals implement corrective measures once they have been cited, because the department doesn't always go back to check. This concerns me because some hospitals, and I know it's a small percentage, but a small percentage can affect a whole lot of people. This concerns me because some hospitals may be chronic violators, and we really don't know. As with all of these patient protection measures, the department should be re-inspecting hospitals that have received deficiencies to ensure that the problems have been corrected and that patients, you, me, our family, friends, neighbors, are being protected. When I talk about nurse staffing, I'm not talking about the occasional violation. It's the chronic and systemic violations that I'm concerned about, and we need to figure this out together. So in conclusion, I know this has been really long opening remarks, but I and my staff have spent a long time, many, many years, and I see some people shaking their heads in agreement. We have spent years and years on these issues, and we really need to have something done. So in conclusion, this will take about another 90 seconds here. The legislature was forward-thinking in passing these laws and was trying to put the safety of all Californians ahead of special interests. But every day that we delay doing something that we could do to protect patients is a day that we put the public directly in harm's way. My goal today is to identify what we can do to move forward and ensure that all hospital patients are protected. It's about time. The department has already outlined several steps it is taking to beef up its enforcement of patient safety laws, and we may learn of other things they're doing today. It is my intention, after the department has finished its testimony, to review those commitments with the department. I will also ask DPH, the department, to get back to the committee in writing on its plans and timeline for meeting those commitments. This will cover steps, for example, to ensure that all hospitals are inspected for their compliance with requirements to adopt CDC-recommended practices for inspection control, to ensure that all hospitals are reporting hospital-acquired infection rates in a consistent, timely, and comparable format, and to adopt improved methods to identify hospitals that have high numbers of hospital-acquired infections and also high numbers of adverse events. I also will outline a list of amendments or enhancements to these patient safety laws and ask the department to get back to me in writing with their comments, which of course I will share with our committee. These would be enhancements to ensure that the department has all of the tools and resources it needs to ensure consistent and universal compliance with the law. You know, back in July of 2005, I held a hearing in my district in Sunnyvale regarding this department's implementation of nursing home resident safety laws. As with now, the department's record was mixed. The department promised to be more proactive in the areas of enforcing state law and proactive in conducting follow-up investigations. I think the situation is better today than it was in 2005, but it's still clear that we are far from having comprehensive systems in place to protect Californians in all health facilities, whether they are in a hospital, nursing home, or other type of facility. And I also need to say that I do understand that the department, with this down economy, has been operating with less resources than it could have. At the same time, I know that for one person to die is one person way too much. And my goal as a senator and for my constituents in Santa Clara County and for all people in California, we need to keep patients out of harm's way. So although we're making tremendous progress, and I want to say that, much more remains to be done, and that is the focus of our hearing today. Senator Negrete-McLeod, would you like to make any comments?
Just want to thank you for bringing this to the forefront.
Okay, thank you very much. And with that, I would like to begin our first panel, which will be focused on the enforcement of policies to prevent hospital-acquired infections. These are sometimes referred to as healthcare-associated infections, but since we're limiting the scope of this hearing to hospitals, we're going to say hospitals. So let me introduce our first speaker, Kathleen Billingsley, Deputy Director for the Center for Health Care Quality, Department of Public Health. And Ms. Billingsley, I would like to commend you on, first of all, the great dilemma you were faced with, and certainly how much things have improved since you've been in that position. So you will be providing the department's testimony first, and then I will ask you some questions following your question, and then following your testimony, and then when we're through with that piece of it, we'll be joined by our first reactor panel, consisting of Stuart Drown, Executive Director of the Little Hoover Commission, Betsy Imholt, Special Projects Director for the Consumers Union, Debbie Rogers, Vice President of Quality and Emergency Services for the California Hospital Association, who will be sharing her time with Anne Marie Flood, an infection preventionist with the City of Hope, and also a member of the Hospital Acquired Infections Advisory Committee, and Carol Moss, founder of NALS Project, who has shown such great courage over the years and has been such a great advocate. So thank you all for appearing with us today. I've given all of the witnesses questions ahead of time. So I'd like you to please make sure to provide responses to my questions in your testimony, and you will find that if you answer the questions completely, I probably will not go off and ask some other questions. So that's just a hint as to how we can kind of keep things running. So you had the questions in advance, and as long as you stick to answering them directly, I will try and stick to asking them just the ones that I put on paper. Ms. Billingsley, as I'm sure you know, I have a lot of questions for you today, so if you could please remain at the table during all of the testimony, I would appreciate it. So thank you for being here. And so this section is enforcement of policies to prevent hospital-acquired infections. We'll start with Ms. Billingsley, who will have 10 minutes to present, and then we'll go to questions to her. Welcome.
Well,
After all that, welcome.
Well, thank you very much. Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity to attend this hearing. My name is Kathleen Billingsley, and I'm the Deputy Director for the Center for Healthcare Quality in the California Department of Public Health. I am responsible for licensing and certification, the Laboratory Field Services Program, and the Healthcare Associated Infection Program. We license and certify over 7,000 healthcare facilities in California. This represents 30 different types of facilities and agencies, including hospitals, primary care clinics, nursing homes, and home health agencies. In addition, we certify over 200,000 nurse assistants, home health aides, and hemodialysis technicians, and 32,000 phlebotomists. Our focus is on patient safety, and our mission is to protect the health and safety of residents and patients. We believe that our commitment to quality care and service aligns with that of this committee. As of December 2009, the Healthcare Associated Infection Program in the Department of Public Health has been funded through the annual licensing fees within the Licensing and Certification Program. At this time, 8 of the 11 positions within the Healthcare Associated Infection Program are filled by physicians, research specialists, and epidemiologists dedicated to meeting the mandates of Senate Bill 739, 1058, and 158. The $2.4 million in ERA funds awarded to the program has allowed the Healthcare Associated Infection Program to expand its statewide efforts for reducing rates of healthcare-associated infections. In early 2010, the HAI program hired a team of 9 regional field infection preventionists to provide on-site support for HAI prevention, surveillance, and reporting in California's approximately 400 acute care hospitals and 61 local health jurisdictions. From April 1st of 2010 to September 23rd of 2010, the IP team has consulted with 204 hospitals. On September 30th, CDPH published on its website influenza vaccination among employees in California General Acute Care Hospitals for the year 2008 to 2009. This was the first annual report regarding influenza vaccination rates among healthcare workers. The report noted that the influenza vaccination rate was 55%, with a Healthy People 2010 goal of 60%. The 2009-2010 report will be published by the end of the calendar year. The following report for this influenza season will be published 6 months following conclusion of the influenza season as required. CDPH is currently conducting an outreach effort to California hospitals, challenging them to improve these rates. In addition, CDPH is fully prepared to meet the January 1st, 2011 deadline to post information regarding the incidence rate of healthcare-associated infections reported to the department. The department recently developed a new survey tool for general acute care hospitals. The Patient Safety Licensing Survey was designed to ensure that hospitals have successfully implemented policies to reduce healthcare-associated infections and are in compliance with health and safety statutory mandates for infection control, discharge planning, immunization for elderly patients, charitable care policies, and other requirements. Prior to the development of the Patient Safety Licensing Survey, the CDPH survey process and tool was last updated 14 years ago. The Patient Safety Licensing Tool is a streamlined survey process that focuses on approximately 100 individual statutory requirements. Compliance with critical health and safety elements include the following: implementation of an effective hand hygiene program, the screening of hospital patients for MRSA upon admission, the presence of a designated hospital infection control officer, and the implementation of an HAI infection control program in the hospital, as well as a hospital safety plan. These are but a few examples. LNC has trained its surveyor staff on the patient safety licensing survey process and will include this training for new staff. The tool was pilot tested, and since September of 2010, LNC has conducted patient safety licensing surveys. LNC provides the facility a copy of the survey findings, and if deficiencies are issued, the facility is required to submit a corrective plan, a plan of correction to CDPH. The Patient Safety Licensing Survey process is a precursor to updating the California Code of Regulations for general acute care hospitals. Beginning in February of 2011, the Department will revise and update the Title 22 General Acute Care Hospital Regulations. This process includes determining which statutes require regulations and would incorporate current Center for Disease Control guidelines and standards for HAI prevention. When these updated hospital regulations are promulgated, the Department will update the Patient Safety Licensing Survey tool to encompass the updated regulations in any new hospital statutes. With regard to adverse events, as of July 2007, over 4,000 adverse events have been reported to the Department. Investigation of adverse events is a high priority for the Department, as these incidents may signal systemic problems with the hospital and may have a greater potential for harm to patients. During fiscal years 2007 to 2008 through 2010, the percentage of adverse events of an imminent nature that are initiated within 2 days of receipt increased sharply from the initial year of this program to nearly 100% for the subsequent 2-year period. In addition, the Department has collected over $1 million from facilities which failed to report adverse events timely. We agree with the Secretary's recommendation and have looked at ourselves the opportunity to currently use OSHPD data, and we will be reaching out and collecting that data immediately to incorporate that in the reviews that we do with respect to infection control in hospitals as well as adverse events. We also have an independent contract which is being executed with the University of California, Davis, to have an independent party review the reporting of adverse events so that we can issue a notification to all healthcare providers in California about potential underreporting. Recently, we have been looking at the number of hospitals that since 2007 have not reported an adverse event. There are over 80 hospitals of the 400 in California that have not reported an adverse event. Some, by and large, they are smaller and rural hospitals, but some of them are larger. We have sent a letter to each of those CEOs asking for an attestation to be signed by that CEO, notifying us as to whether or not they have or have not reported an adverse event. Also within that attestation statement, they must indicate to us how they have gone about reviewing their internal processes to determine whether or not they have reported an adverse event. Many of them, unfortunately, are. Yes, ma'am?
You're doing a great job. You're already going into the second topic.
Oh, okay. Let me just finish my last paragraph, and then I'll go ahead and stop. How's that sound?
Sounds good.
Great, great. Since July of 2007, the Department is authorized to assess civil penalties against licensed hospitals for violations of state laws and regulations that constitute immediate jeopardy. Immediate jeopardy is defined as, in statute, means a situation in which the licensee's noncompliance with one or more requirements of licensure has caused or is likely to cause serious injury or death to patients. From fiscal year 2007 and 8 to 2010, the department has issued 157 administrative penalties and collected over $3 million in fines. Currently, 40 penalties are either in the collection process or being reviewed. I welcome the opportunity at this point to answer any questions you may have.
Thank you. We're going to spend just a second figuring out. We had 16 questions here for you, which obviously we're not going to go through all 16, but we're just going to figure out which are the main ones to ask right now, and then we'll ask the department to provide information to me that I can then give to committee members also as to answering some of the other questions. First of all, I find it interesting that there are 80 hospitals that must think they're perfect.
Well,
and that's not one of my questions, but I'm just saying, I just find that fascinating, and I'll go on to my questions, unless you wanted to comment on that.
No, I think that some hospitals, having reached out and spoken to some of the hospitals, believe that when they report what's defined as an unusual occurrence in statute, qualifies as an adverse event. And as you know, in SB 1301, the adverse events, there are 28 of them, are very clearly defined.
Yes.
And so there, again, tends to be some confusion, although we have sent out significant amount of communication to make sure that people understand the difference between a complaint, an unusual occurrence, and an adverse event.
Okay. And I would also say that, one of the reasons for the hearing, besides figuring out exactly what the department is doing and not doing, is to figure out, since I wrote several of those laws, are there things that I need to go back and refine if there's something that's not clear for people and hospitals, et cetera, to understand in terms of implementation. But that's something that we can talk about even some other time. So I will just ask the first 5 questions here. We hear consistent complaints that the department is not taking its responsibility to enforce the hospital infection control laws seriously, that the department is not proactive enough, that it must be prodded in order to get it to follow the law, that it has consistently delayed developing regulations and revising inspection procedures. What assurance can you give us that DPH intends to take its enforcement responsibilities seriously in the future and won't simply let this slip once the pressure is off to do so?
Well, I think that we have taken some actions very promptly. With the inclusion of the HAI program as a part of the Center for Healthcare Quality. We received very generously 11 positions, which became effective for us on December 9th of last year. 2009. By January 5th, we had filled over half of those. So we feel as though we're moving very quickly. I also feel as though we are definitely trying to catch up and get our program moving as quickly as possible. It's a very, very committed group of individuals who, again, see this as important an item as everyone in this room does. And I believe that they are very dedicated to making sure that not only do we look at hospitals, but we make sure that we help make hospitals better in terms of surveillance and prevention. I think the patient safety licensing survey is not a tool that was quickly put together in order to meet some type of deadline for a committee hearing. This was constructed based upon the fact that when looking at 739, 1058, and 158, and all of the legislation that has been enacted since 2006, there was a great opportunity for us to do two things: to meet our requirements by surveying and conducting enforcement activities, as well as to begin the revision of the entire hospital survey process. Historically, there have not been resources for this program to do any hospital oversight. So now we're developing a real-time tool, and we are out surveying and issuing deficiencies for violations of the law.
Anything in particular, though, you might want to say on the delay in developing regulations and in revising inspection procedures?
We have revised inspection procedures. The development of regulations within the Center for Healthcare Quality has been one that did not have resources dedicated to doing that. We have now developed a regulations unit, and they have done a full assessment of all the regulations that are required within the center, and they've developed a very extensive timeline. It has been 20 years, 30 years, 40 years since anyone attempted to look at Title 22 and to begin these revisions. I'm very proud of the team that has been put together that has developed this timeline. They have also scheduled outreach efforts to hospitals and to all stakeholders to participate in this process.
So have have the regulations been implemented?
No, they have not been written. We now have a unit, and we now have a timeline, and if there are some specific ones, we'd be more than happy to provide you in writing with an overview. Certainly the ones for the HAI program are very high on our list, or any other ones related to the implementation of administrative penalties. Okay. That's also very high on our list.
Thank you. We would like to see from the department information on all of the timelines on developing the regulations, and including the important timeline of when the regulations will be implemented.
Oh, okay? Certainly, yes.
Thank you. Okay, we'll go to the next question. Why has it taken DPH so long to develop a new survey tool and to begin inspecting hospitals for their compliance with the hospital infection control requirements in SB 739, SB 1058, and SB 158, some of which date back from 2006?
I believe that
I think you addressed it.
I think somewhat. I did address it. I did address it, and I think that we're on the right pathway with this tool. I think we're being very proactive. We've developed a good tool. We've tested it. We're now piloting it. We are very actively engaged in making sure that we complete the survey process as well as issue deficiencies for any violations.
So are you saying the tool is now being implemented in all hospitals?
Yes, it is.
And are you hearing back from all hospitals?
We are on site conducting survey processes.
Okay, so a better way to, more accurate way to phrase it would be then, has the survey tool actually been used at all 400 hospitals?
No, it has not been used at all 400 hospitals.
And about what percentage?
We just started surveying to all hospitals, having completed our testing and our pilots beginning in September.
So, and I'll say this to my staff at the same time, and maybe it's in one of the comments down the line, but I really would like to see a timeline on when the survey tool will be used in all hospitals, all 400. And then as part of that, I also would like to understand, for us to understand, to be included in that, how's that information going to be used? Once you have the survey tool, what are you going to do with it? How are you going to use it? Or do you know now how you're going to use it?
Well, the survey is used, as you know, to go ahead and assess compliance with 100 different mandates. And the outcome of these surveys will then drive the feedback and direction that the program should take. So, say, for example, we find that hospitals are having difficulty with hand hygiene programs. That's nothing but an opportunity for us to basically go back, look at that, and proactively work with providers and set expectations. That also basically means there will be enforcement behind that. So there basically is a two-pronged approach when you have a violation. You go down the quality improvement pathway to basically consult with your providers. Title 22 requires licensing and certification staff to consult with providers. But again, that is not always successful for every provider. And so therefore we turn to our enforcement actions, and based upon that, we follow that pathway.
So as an example, if, let's say, out of the 400 hospitals that when you have actually surveyed all 400 of them, and that'll be in the timeline that we receive, let's say that there are 20 hospitals in particular that when it comes to hospital-acquired infections, they have a very, very high rate. Then what do you do about those 20 hospitals?
Depending on the findings, we would require, again, based on these violations, for the hospital to develop a plan of correction. If we have concern as to whether or not that hospital will be compliant, or the extent of the problem is so egregious in nature to cause concern, we would be back in that hospital repeatedly until such time as we felt the hospital was compliant. That there are other actions that can be taken on the federal side as far as other types of oversight and, again, potential termination of a hospital's CMS agreement, as well as the revocation of a license. Depending on, the extent, we use all of the enforcement tools we have in our toolbox.
And what is the department's definition of compliance in this area when it comes to hospital-acquired infections? How do you know when they're good? How do you know when they're not so good?
Well, I think basically that's a very difficult question.
It's not on my list, but I just thought of it. So.
Right, and no, it's basically you would look at standards or rates for infections, and you look at central line associated bloodstream infections, and you look at many hospitals in California, and right now they don't have. There is no incidence of that in their hospital. So the goal is 0. Okay, so basically that's what you're trying to achieve. You're not trying to achieve something less, a 10% rate. That's not where you want to be. So basically you look at where they are in the spectrum, what their rates are compared to other hospitals, and what processes do they have in place to correct this. Are they successful? Are they doing the right thing? Are they taking this seriously? Do they have enough resources to be able to address the issue?
And somewhere in 2 places, both in DPH's internal system as well as in communication to hospitals, is there that definition that compliance when it comes to hospital-acquired infections means the hospital doesn't have any, that it has 0? Is that actually written somewhere?
Yes.
Okay.
I mean, there are a number of collaboratives in California that we as CDPH work with, and the goal is 0 for many of these infection rates. This is not something that is, we agree. No one wants to see these or have these occur in hospitals.
Thank you.
I think that's the point.
Okay, we've gotten through 3, and we're going to do 2 more.
Okay.
At least 2 more. You've told us that roughly 85% of hospitals are now reporting their rates of hospital-acquired infections to the NHSN, which is what I'm going to call it, National Healthcare Safety Network, and have authorized DPH to access the information they've reported to NHSN to enable the department to analyze it and post it for public access starting in January as required by my bill. So that means then that 15% of the hospitals have not authorized DPH to access this data, which means the public then does not have access to the data. you've also told us, or at least doesn't have access to data in an easily accessible format. You've also told us, though, that you expect 100% of hospitals to enable DPH to access the data by November 2010, and it's now almost November 2010. My questions in this area are threefold. First, who are the hospitals that are not currently reporting their hospital-acquired infections to NHSN? I.e., that makes up the 15% of the non-reporting hospitals. And can you provide us with that list? Is the first of the three small questions here.
Yes.
Thank you. Second, what makes you certain that 100% of hospitals will be reporting their HAI rates to NHSN and authorizing DPH to receive the information by November 2010?
Well, fortunately, we did receive the $2.4 million in ERA funding, which allowed us to hire the infection preventionists in all of our different regions. And their primary focus has been spending time with hospitals, helping them sign up with NHSN. Unfortunately, it's a far more complex system than one would have expected. They may have signed up for themselves in order to be able to enter the information, but then they have to go through a rather sometimes arduous process in order to be able to grant us the authority to be able to access their data.
Does the department know what percentage of hospitals as of today that have authorized that DPH have this information?
I thought that was the point, that it's 85% of hospitals currently have granted their...
I was hoping maybe it was a little different by today.
Pardon me?
I was hoping it was a little different by today.
No, I don't know the exact number today.
Like a real-time number?
Sure. We'll be glad to give you a real-time number as well as a list of those hospitals.
Thank you. And the third part of that question is, should my SB 1058 be amended to require hospitals to report to the NHSN and to authorize DPH to access their HAI rates on an ongoing basis and to provide penalties if they don't?
I think that there is an opportunity to look at SB 1058. There are a few items in there that I think would help with the type of data that we're getting, whether it be through NHSN or clarification. There are also some guidelines that CDC is issuing that are upcoming to us that would be beneficial to put in 1058. So I think it's a little bit broader discussion than we have time for today,
right.
But I would welcome the opportunity to provide you with that information.
Thank you. Next question, the fifth question here. You've told us that the department did not determine that it had the authority to require hospitals to report their rates of hospital-acquired infections to NHSN at the CDC until April of this year. Because of this, the data it has from hospitals for 2009 and the first part of 2010 was collected through paper forms. Hospitals didn't report the data consistently, and some didn't report at all, which is troubling because the first public report of these hospital-acquired infection rates required on January 1st, 2011, will be based on this data, which doesn't sound like there's much of it.
Well, there is data. It isn't the much of it, I think, that really is it. It's really whether or not the data that's been reported on paper forms is of the quality and has the rigorous nature that NHSN does in terms of requiring specific data elements. We reviewed in great detail the legislation to determine our authority, and we did not believe that we had the authority to require hospitals to use NHSN. We also did not have the authority to require a specific form or content to be able to be used. This is something that was brought forward. and was made clear that we had these difficulties. It was also discussed in detail by the HAI Advisory Committee, with their recommendation that there be modifications to Senate Bill 1058.
And you will share with us, and the department will share with us what those suggestions are.
I will share with you the ones that we had prior, and I would also welcome the opportunity to share any other current things that we have identified as well.
Thank you. How useful will the data be for purposes of comparing hospitals on their infection rates as intended by SB 1058?
Well, I think we've done the best job that we have with the information that we have in terms of reviewing all the information that's been submitted, going back to every California hospital and allowing them to review this again. So any information that was given to us in 2009 to go back and clarify information. There's a lot of different opinions as to the value of the data because of these problems, but clearly, as CDPH, we are viewing this as a mandate, and our report will not only report the data, but will also provide the detail regarding any of the data concerns.
Thank you. I know at some point we need to go on to the next section. I would just say that I think we have at least two problems here. One is the quality of the data you're receiving, and then number two, the numbers of hospitals that are still really not reporting. And I just have to say that when hospitals don't report, it's human nature to ask, what are they afraid of? And given that it's almost 2011, I think it's more of a 1970s mentality that you can just stall and not report, and nobody's going to notice what you're not doing.
Well, we also will make sure that the information that is posted on the website clearly articulates those hospitals that did report and those who did not. Again, with the recent 2008 and 9 influenza report, we listed each hospital, what their individual rates are, and whether they had or had not reported. And we did give, for instance, with the influenza report, we did give them an opportunity to submit that data again. And if it wasn't submitted, the hospital was identified as a non-reporter.
Thank you. Senator Negrete-McLeod.
What's the consequences of not reporting?
I would probably have to get back to you for sure to see if I have any consequences for not reporting. There are some consequences for not reporting influenza data I'm aware of. Can I give that back to you as part of one of the responses?
Well, I would venture to guess if there's no consequences, why the heck would I even bother to answer your questions?
I thought Senator Negrete-McLeod asked an excellent question, and there ought to be some consequences. When it comes to public safety, health, people dying, yeah, something ought to happen if you're hiding and you're not reporting information. Okay, let's go on to the reactor panel. Thank you. And then the other 10 questions that I was not able to ask, if the department could respond to them also. And of course, I will share all the information with everyone on the committee and see that all the consultants have them also. Okay. Okay. Reactor panel, we'll start with Mr. Drown, the Executive Director of the Little Hoover Commission. Each panelist will have 3 minutes, which I know is not very long, but we're trying to cover a lot of information.
Good afternoon.
Good afternoon.
I'm Stuart
Welcome.
Drown. Thank you very much for holding today's hearing on this important public health issue. In 4 reports over the past 4 years, over the past 8 years, the Commission has advocated for structural reforms to strengthen public health as one of the core components of public safety. It sees public health on par with emergency services and fire protection. In its 2003 report, the Commission called for an aggressive response to eradicate healthcare-acquired infections and repeated this appeal in 2005. This legislation ultimately was passed in 2008, calling on the Department to bolster the state's ability to track and prevent healthcare-acquired infections and to hold hospitals accountable. While encouraged by the progress the Department has made to date in other areas, in this area, the Commission feels that the Department has not shared its sense of urgency and needs to be more assertive in fighting healthcare-acquired infections. In the interest of public safety, this should be a top priority for the Department. This is an area where the Department can and should lead in driving the state's efforts to eliminate preventable infections.
And may I say one thing? Please also, I mean, a lot of good information has already been given. So if you have any questions or comments related to what has already been said, feel free to use that information in your comments.
Okay. Well, I mean, we would like to acknowledge...
This is a reactor panel.
Right, and they have made considerable progress in a lot of other areas, and I'll talk about a little bit in my discussion about briefly what we see some of the issues are. But you know, in the Commission's view, this is an area where we need a very strong voice for public health. It has to be independent. We've recommended that they move the Department of Public Health out of the Health and Human Services Agency, have the department run by a state Surgeon General, and have that Surgeon General report directly to the governor. And we feel that this would give the profile as well as the kind of independence to be something of a bully pulpit
Thank
for
you.
public
That's
health.
kind of useful information for us to, yeah.
So, and in this way, it could be more proactive instead of just reacting to legislation that's been passed. And in fact, one of the concerns for the Commission is that the Department's response has been reactive and more process-driven as opposed to proactive and more outcomes-driven. They spent a lot of time developing processes with the help of the advisory committee, and that's to be commended, but we're looking for a more aggressive start. Many of the department's implementation activities started only recently, some 2 years after the legislation is passed. For example, the department had not determined which hospitals would be subject to the public reporting legislation until just 2 months ago. Also, the department is just now piloting this patient safety licensing surveys to evaluate hospital progress and implementing reforms. At this point, there's still a lot that we don't know about what the hospitals have done to implement patient safety reforms, what challenges they're experiencing, and what the state can do to help. The Commission is concerned, well, it feels that the Department can and should do a better job of posting where it is in this process. And they have a page on their website for their HIA program, and we feel this is an opportunity that where they can bolster kind of where they are in the process and the complicated challenges, well, the challenges that they face that complicate progress in this area, because we know that it is complicated.
Other point, you're over time, but I interrupted you, so I accounted for that too.
Okay, I've got just the one key thing. Okay, I'm sorry, have I interrupted you?
So do you have another key point you want to make?
Yeah, I think in addition to the further structural reform, there's an opportunity here. They need more flexible funding. Most of their funding is tied up in categoricals, federal funding. This is where they could benefit from some help from the legislature. The Commission's concerned that much of the HIA staff is being helped now by temporary funding from ARA, and what will happen when that money runs out, we'll lose. What will happen? How will they be able to pay for those other 9 employees? So thank you for this opportunity to speak. I look forward to working with the staff
and the
department.
Thank you very much. And that was the kind of testimony that was really helpful. It's on point and what we can do, and talks about the situation as it really is. So, Ms. Imholz, Consumers Union.
Good afternoon, Madam Chair. Thank you so much for this opportunity to testify about a matter so important to Californians and for your steadfast leadership on preventing medical harm to patients at hospitals over the many years. Overall, implementation of the California laws on hospital infections has been a major struggle, to cut to the chase. We've yet to see the agency assert a leadership role, and frankly, when it gets down to it, we can have all the statutes and all the details on the books that we want, but if the will isn't there to really step out front and lead, it's going to be a problem. We're pleased with some of the positive steps recently with the release of the infection vaccination report and the commitment to get the data hospital-specific up and running on January 1. We are concerned, however, that the quality of the data, for the reasons Ms. Billingsley has outlined, both the 15% non-reporters and the paper forms are going to be problematic in terms of the quality of that data, but commend them for taking the stand to put it out into the public realm. We know there have been budget shortfalls, staffing issues, et cetera, but frankly, these issues are not unique to California. We've been monitoring the implementation of these laws all across the country, and just about every state, as we all know, is faced with similar kinds of budget problems. We've had different reactions in different states, some really going gung-ho with the patient protector role, others being more hesitant. But in all of them, I think in none of them have they had the financial support that they really needed to fully do the job. However, in most, they've really stepped up to try to do what they can. And I guess that's our pitch to the department, would be to step up to the leadership role, do what you can with what you have, get something out there. We've been monitoring over the past several years all these laws. We've been at all the advisory committee meetings, met with department staff, done Public Records Act requests, 2 reports, which we've given to the committee. And based on these, we are concerned with the approach going forward. 3 short things I would mention are, we do think the department has the tools and the resources it needs. It's got legislative dollars. It's got licensing and certification fees now due to the reorganization. It's also got federal ARA dollars. And so we really feel there's no further really reasons for delaying the regulations that need to be put into effect, et cetera. Secondly, we cannot let, and the department cannot let, the perfect stand in the way of the possible. I heard Secretary Belcher use that term yesterday, and I'm picking it up. Because when it comes to the infection disclosures, it will never be perfect. The data will never be perfect, even if it's all electronic and all through NHSN. But there's always the opportunity for hospitals to correct. So we just have to get it out into the public realm so that we can spur improvement. And the third point I wanted to make is that we've heard several times today about reminders to the hospitals, suggestions, collaboration, and that's all fine, but that's really not what's going to drive the compliance with the law. I think Senator Negrete-McLeod really hit it on the head. What's the consequence?
Yes.
Where are the regulations? If I'm running a hospital, and I believe everyone has good intent, but I'm going to look at where are the regs, where are the penalties, what do I have to do to comply with the law? So given the public dollars invested and the lives at stake, we estimate, Little Hoover, I think, estimated about 10,000 Californians each year who die from hospital-acquired infections, and that is way beyond what's right. And Ty and Carol can attest to that. I'm glad they're both here. So thank you very much.
Thank you. And as has been expressed, there are 15% who are not reporting. So just using the honor system hasn't worked. And that means, now that we've tried that, there needs to be consequences. Human nature seems to respond to consequences more. Thank you. That was excellent. Next, we have Debbie Rogers, the California Hospital Association, and Anne Marie Flood, HAI Advisory Committee. Welcome both.
Thank you, Madam Chair and members. We're delighted to present to you here today. Hospitals take very seriously our fiduciary responsibility to the patients that we care for every day, and take very seriously the challenge that reducing hospital-acquired infections provides. We support public reporting of hospital-acquired infections for the reasons that we've heard. We know that the first report is probably going to be a little bit challenged. I think now that hospitals will begin using NHSN exclusively for these infections, I think we're going to see more reliable data perhaps in a future update of that. I'd like to give you my personal commitment, and certainly the commitment of the Hospital Association, that we will reach out to those hospitals who have not yet signed up for NHSN or have not yet made it into the department's user group. We're absolutely willing to help with that in any way possible because we need to get them registered and understand that they need to do the right thing. Hospitals work hard on hospital-acquired infections, adverse events, and other things that we'll talk about today. And in fact, many hospitals in the state belong to patient safety collaboratives where they're working on these issues of hospital-acquired infections and sepsis and other things to try and ensure we can get the lowest possible rates that we can. I'll let Anne-Marie address if it's possible to get to zero. But our goal as far as patient collaboratives, patient safety collaborative opportunities, it's our hope that 95% of the hospitals will have an opportunity to participate in this way where they learn from each other of things that have helped them. You know, certainly the CDC guidelines that we've heard referenced, those sorts of things, but there's also practical frontline things that hospitals can do that have worked in certain hospitals, and so we're very pleased about that. We're also pleased about the patient safety licensing survey that sets the roadmap both for hospitals and surveyors of what kinds of things are expected for hospitals to do, and then on the does the department have enough teeth, I would say probably 20 or 25% of that survey is related to infection control types of things. If hospitals aren't doing what they're supposed to be doing, then the department has the ability to create citations, require plans of correction to get hospitals back on track to do what they need to be doing. Thank you.
Thank you. And I've always enjoyed working with you. You're a person of your word, so I look forward to these improvements. Thank you.
Thank you, Madam Chair and members of the committee. My name is, am I on? A little closer? Okay, thank you. My name is Anne Marie Flood. I'm an infection preventionist. I'm a member of the Healthcare Associated Advisory Infection Committee, and I'm here speaking today on behalf of its chair, Kim Delahunty. And we have, the following are some of the committee's concerns. The laws which drive our work require outcomes be both publicly reported and risk adjusted. I mean, we can all agree that a half-bound baby in an incubator, a 23-year-old man who has a broken leg after a car accident, and the mother waiting for her, her bone marrow transplant to engraft are completely different risk categories. I get very passionate about my work. Okay.
That's good.
Okay. So the committee and the CTPH are torn between the deadline in the law and the requirement to be risk adjusted and therefore meaningful. When we talk about meaningful data, we have the recently reported hospital-specific immunization rates. And the committee did advise that CTPH not do hospital-specific rates because it felt that the data was flawed in many ways and unverified. The data has now been published, and we have, as a result, 8 hospitals who have more than 100% of their employees reporting immunizations or declinations, up to a rate of 130%. We have CTPH allowed for the gathering of 2009 outcome data using a form that did not allow for risk adjustment. This was corrected as of April 1st, 2010. However, the information on such healthcare-associated infections as central line-associated bloodstream infections, MRSA, BSI, and VRE BSI.
We're already, excuse me, we're over the time already. If you want to make 1 or 2 points, okay. And we do have your written testimony.
Okay. The other point is talking about opportunities for improvement. The language as it occurs right now with surgical site infections. There is no clean GI surgery under CDC recommendations, as outlined in the law requiring the reporting of clean and clean contaminated GI surgery. Also, it appears to suggest in the language of the law that all of these groups of surgeries be reported all together, and these surgeries have very different risk stratifications, appendectomy versus colectomy versus hemorrhoidectomy, et cetera. Thank you.
Okay. So we have Ms. Carol Moss. Welcome.
Thank you so much for having this hearing today to bring the visibility to the table. I'll make it brief since many of my points have been covered. There has been some improvement in the movement of the committee. I am on the advisory committee as a voting member. I joined this committee and became a very active participant in this role after the death of our son, Niall Moss. My husband Ty and I are here today in honor of him, with the strength of God, to protect the citizens of the United States and of California from this happening to them again. Unfortunately, being a part of this committee, I see things that I'd like to make sure that the public is aware of. And I can tell you that what I find constantly is the will to make this happen. It's not there on the part of the department. There are just too many excuses. There's a constant echoing of, we don't have the people, we don't have the money. To answer your question, this Department of Health has been given what they need to enforce this legislation, this life-saving legislation. And I believe that with what you've heard today from Kathleen Billingsley, with her commitment, I'm very hopeful that we're able to enforce the legislation. And as we mentioned, when the Hospital-Acquired Infection Committee asks the Department of Health, who are these hospitals that haven't signed up yet? Who are they? The response we get back are, by law, we're not required to tell you, essentially, at our last meeting. So we need to work in partnership with the department, but we need to have a Department of Health that believes in the legislation, that believes that what is in place is these infections are preventable, and that we're going to all work as a team to get this done, because they're doing it in other states and they're doing it in other countries. My family has just suffered another major, tragedy from MRSA. My cousin, who was 50, had to lose his legs to save his life. And I just bring this up to say that this sense of urgency has never stopped. We are still in the middle of a major epidemic that needs to have a sense of urgency defined, and whatever the department needs to get this moving and enforce the legislation, that's what we need to do today. So thank you very much for your time.
Thank you, and it will be made public,
That's what we need.
the ones that are still not reporting, and what information
Yeah,
they do have to share. The public will know.
that's what we need. Thank you.
Thank you. My first three questions would be for everybody, and then I have one or two specific questions for each person, and then if at any point, Senator Grady McLeod, if you want to add something, feel free. You want to start?
First, I'd like to, the hospital representatives, for those that are actually working to answer the questions, want to thank them for their participation. And I'm not sure that I understood that those hospitals that are not responding, are they like 100% clear? Is that why they're not responding? Or are they just not responding because they don't think it affects them? Or it's in their best interest? Or does anybody know the reason?
If I might, the process of signing up for NHSN, while it sounds simple to all of us in the room, why can't you just do it? There's a process for that. Then apparently there's a process to sign up for each of the types of infections that need to be reported over. So in my mind, I think some hospitals may have actually signed up for NHSN, but haven't gotten down to the detail of signing the rights over to the Department of Public Health.
If I could comment on that process, having joined NHSN, and it is one of those things, if you've ever applied, done a long form online, and then turned to the next page and realized you've missed the one button that was on the lower right-hand corner, it's almost that complex. You're looking at a 8x11 page with something like 25 different elements that have to be ticked off just so, and making sure you're moving forward in that process each month sometimes to confirm those rights. So it's not as simple as I thought it was going to be.
Well, I guess my next question would be then, why is it so difficult? Why don't we have forms that say, did you have ABC? And if you answered yes on ABC, then clarify why you answered that, rather than having this hodgepodge of questions that make it so that people don't want to ask. It's kind of like your income tax.
It's not actually, it's not actually so much the questions, it's just ticking off the boxes, and just so. You have to describe what your practices are going to be for the following month, okay? What surveillance you're going to be performing. You have to click off, there's, most of what we're talking about today comes under the patient safety format, and most of them come under device related activities, your central line insertion practices, your CLAPSIs, and then with the laboratory ID events for MRSA, BSI, VRE, BSI, and CDI, BSI, and CDI infection. So it's not as easy as it could be. It did take me a couple of tries to do it. That being said, it is 2010, and I agree with Carol. If you haven't at least joined up by now, you should be at least joined, at the very least.
Are these questions that the federal government has imposed, or are these that California has imposed?
Well, the system is a federal government system, and now that many states are required to report, and the federal government has a reporting requirement that begins in January, we know that they're working to simplify the system because every hospital in the nation will be submitting some data.
And to simplify things for implementation here in California, we decided collectively that we would go through NHSN, because why have the hospitals, chains that have hospitals in multiple states, have different protocols to learn, et cetera. So it really was to simplify things here in California. We melded it into the law here.
It allows us to compare ourselves to other states, too, which I think is going to be really helpful.
And it is considered the gold standard for surveillance.
Yeah, they've covered a couple of the points I was going to mention.
Okay.
But bottom line is, the AFL was sent out from the department over 2 years ago. This is plenty of time to have registered and implemented. It's just part of what they do.
Does each hospital have a specific person that does this? So if that's their job, if that's their only job, then there's no excuses that you don't learn something.
It's not actually. The way the system is set up, you have an administrator who's kind of like the keeper of the data, and you can have persons who are allowed to enter in data, have levels of authority. But essentially, in some hospitals where there's only one person, they're the administrator at setting it up and doing the data entry, depending on the level of their administrative support.
If I could suggest, if we could get the list, I will work day and night for 2 weeks and then come back and sort of see where we are. Or, I don't know what coming back means. The department might have to tell us who, or we could have another hearing. But the department can share with us who's still not done it all correctly.
Okay. So for the department, do you think it's just something willful that some hospitals just decided, I don't have to do it up yours, yana, yana?
No, I don't think it's an act of deliberative non-performance. I think that, again, the system is very complex. People didn't understand it. I think that we have provided more and more direction. I think it is a time period now where we're down to the final few, and we need to personally visit each of those hospitals to send the message that signing up for NHSN and reporting is a requirement.
Do you have anybody on your staff that's an expert in this that could go aid?
Yes, we do. We have the 9 infection preventionists that are funded through the ERA funding that we discussed previously, and they're all assigned to different geographical areas within California. Since they came on board at the beginning of this year, they have personally visited 204 hospitals, and although they expected to spend more time on surveillance and the prevention of HAIs, they've had to spend an inordinate amount of time teaching people how to sign up for NHSN, sitting down with them and actually doing it.
But that's
I think
a good thing if you actually
with the
teach
list that we can have of the 15%, we will deploy the staff to target each of those those hospitals.
Okay.
And Debbie's agreed that we can contact each of their CEOs. Okay, we all are.
This one is yours. Okay. The chair is back. Madam Chair, I was just playing bad cop, so I'm okay.
Thank you, Senator Negrete McLeod. Okay, question for Ms. Rogers. My recollection is the hospital signed off on the hospital infection reporting language in SB 1058 on the reporting of surgical site infections, which establishes the categories for reporting, such as orthopedic, cardiac, and gastrointestinal. Why did the hospitals come back after the bill was passed and argue that the language and definitions were unworkable when they were part of the solution? And this feeds some suspicion that hospitals are trying to whittle down the reporting requirements to the specific surgeries that they're already implementing infection control measures for.
You know, Madam Chair, that's an excellent question. I liken that section of law to many term papers that I turned in during my college years, where I thought that I had written a really terrific paragraph or a really terrific sentence, and then I got comments back from my professor asking what was I really trying to say. We were having a conversation with some of the infection control providers in that an earlier version of the bill, apparently the context of that language made more sense. We in no way want to get out of reporting the infections related to the joint replacement and cardiac surgeries and GI surgeries. It has to be done, this is my opinion, in a way that's consistent with the way that NHSN defines it. One of the good things about going to the NHSN model is that we will have standardized definitions, and we'll all be doing it the same way. Conforming to their language or their surgeries, and Anne Marie knows much more about it than I do, would be a way that we could be comparable to other states. So we were absolutely neutral on the bill. We believed that the language that was in there would get us where we all desired to go, but in looking at it afterwards, some of the infection control folks decided that it's not as clear as it could be.
Thank you. Another question for you. Are hospitals clear on what they will have to do to implement the requirement to retest patients who show evidence of increased risk of invasive MRSA prior to discharge, and if not, what additional clarification is necessary? There isn't a CDC or any sort of accepted definition of what it would look like when a patient is at additional risk for invasive MRSA, or the phrase that's in the bill. So we've looked to the CDC for help with that, and there is no recommendation from them. There's no recommendation that we know of from any of the infection control bodies, and so this requirement goes into effect January 1st, which is very serious. But we're not sure how to define that, and there aren't any national bodies to look to define it. Okay.
Senator Alquist, could I make a comment on that?
You may, and then I would also, if Ms. Billingsley has a comment on that also.
So the intent of that portion of the law was so that we could be aware if a patient went into a hospital and they were tested for MRSA and they came up negative, then on their way out the door, they needed to be tested to see if they had acquired infection on the way out. That's the intent. So if you think about the intent of legislation, it is simple to take that in mind and do what needs to be done. Those who did not test should be tested on the way out.
First we'll go to Ms. Billingsley and then to Ms. Flood.
I've often said one of the most difficult pieces of the job is sometimes taking what is written in a piece of chapter legislation and then trying to implement it, because of the fact that my difficulty, although I have my personal interpretations of what the law means, I don't think it's always appreciated by everyone else. So we have to be very, very careful and work with our legal staff to make sure that we are following the exact, the exactness of the law. And this particular subject that you're talking about now, with the MRSA going into effect in January, has caused us some concern in terms of interpretation.
If I could comment, too, on the process of retesting. The legislation calls out for invasive disease. I would, if there's scientific methods and you can propose doing a risk adjustment, everyone should know what their rates of MRSA infection and colonizations are based on this legislation. And we know with the advent of testing of an admission who has it on arrival. What my thoughts on the matter is, on the subject, is that hospitals could be asked to look back to see who developed MRSA infections that were negative subsequent, and those classes of patients, looking at a risk adjustment for the specific to your hospital for retesting, like those groups of patients. In other words, if you find that you have a bunch of surgical patients that test negative, then during the stay, a certain proportion of them, greater than the rest of your population, test positive, then that might be that group that your hospital, based on your patient's needs and your patient's requirements, might want to retest. So doing a risk assessment based on the CDC guidelines on multi-drug-resistant organisms that were published, looking for ongoing transmission, that would be a more logical grouping way to address the law and to address the people who are at risk.
Senator.
Ms. Flood, how does City of Hope keep their infection rate down? Because you have the most vulnerable patients at your hospital.
We have the highest rate risk patients. We do have high rates of central line associated, and I have to say central line associated bloodstream infections, which means that bacteria are found in the blood in the presence of a central line, as opposed to central line related bloodstream infections, which is a higher standard. The law calls for central line associated bloodstream infection to NHSN. Our patient population is unique in that we have patients in, I can tell you, my running joke is on the 6th floor. If I added up all the white cell counts of all the patients, all 36 patients on my 6th floor, I wouldn't get one adult normal. So there are times, and then what we do to our patients, that we have to treat them, we have to eradicate their fast-growing cells, which strips the gastrointestinal lining, causing this basic like sunburn from people's lips to their rectum. So all that bacteria goes floating back and forth out of the GI tract into the blood. Did the staff do anything wrong? No, we have good evidence. If you're looking at central line insertion practices, we've got good compliance with that. We keep improving our hand hygiene. We have re-educated all of our nursing staff that this is how you access a line. We are going to drive to get to all preventable infections out of the way. But some infections, especially in high-risk populations, are not truly preventable.
This hearing is taking more time than we thought, and we will take the time that it needs. So, Ms. Billingsley, it sounds like we'll have some things to work on very quickly.
Yes. We
When it
certainly
comes
will, and
to-
we welcome the opportunity to provide you with
To work
our
with your
feedback.
department quickly,
Yes,
yes.
the department will definitely be doing that.
Ms. Moss?
Just one thing. I did want to clarify the question about what type of enforcement activity can you take when a hospital does not report their infection rates. We can issue a deficiency, so we would basically write up the hospital in a survey report, findings that we normally use, and basically issue a deficiency for violation to not report.
And the
There are no other
the question, though-
financial penalties associated with that, but I wanted to make
Okay.
make sure that I was clear.
But the real question is then, what is done with that report? Does the public know?
That report is published on the Health Facility Consumer Information System. That deficiency is listed as the hospital not being a reporting hospital, as well as on a regular basis with our website posting, those hospitals are listed as not reporting.
Okay. So I would suggest that, number one, whatever is occurring right now on that point really doesn't seem to be working, since you still have 15% who are not reporting. Number two, that information has to be made easily accessible to the public, which is not now. And number three, I don't know if we're talking fines or not, but I do know that the current system is not working and that we will have to look at other options. Ms. Moss, I was going to ask you, I agree there needs to be more consistent protocols for what hospitals do with patients who test positive for MRSA. Are there standard protocols that could be adopted in this area? And anyone else who would also like to answer that?
Well, I know that with the VA hospitals, they're a fantastic example of what we should be doing. That's our federal government who says if you're tested positive for MRSA at the door before you pass the line, you are put in isolation so that you don't infect the rest of the community.
And that's
you're
not
treated
done here?
appropriately. No, that's not being done today. We have several people that have let us know that their family members have been tested positive, and they've not been isolated. And in talking with some of the folks on Kathleen's team, when talking with them and reporting in on this, this is not unusual, and there's nothing that's done about it. So this is critical to the legislation, and it's a proven best practice to let's treat the patients for what they have, and then let's make sure it's not spread throughout the community of the hospital.
Ms. Billingsley, could you also comment, and then anyone else who would like to, Ms. Rogers?
Well, I'm not aware of Carol's interactions with the different field and the discussions. What I have also often put myself in the role of just, if you could please give me examples, and we will definitely follow up with any conversations or lack of dissatisfaction with any action that's taken on the part of the licensing and certification staff. We take that very seriously, and I do receive feedback from a variety of stakeholders, and I believe that that feedback will only make our program stronger. So we will have some further discussion in this area.
Senator Altos, can we just ask Kathleen's opinion of this one fact, because it is
You could ask through me.
Okay.
Yes. Ask me, and then I'll ask her.
Okay. So what would be the recommended
So she won't be
approach?
surprised. Okay.
Yeah, what would be the approach?
Okay, I
in
would.
testing
So,
positive?
Ms. Billingsley, what would be the recommended approach? And then I would add to that question and ask, what is the standard protocol if, when a patient is admitted, he or she has MRSA?
I'm going to ask Anne Marie to provide that
So there are
clarity.
two parts to the question.
Oh, okay.
One was Ms. Moss, and the other was mine.
Okay, Anne Marie, can you answer that?
I can speak to what the CDC guidelines on the recommendations for reduction of multi-drug-resistant organisms in healthcare facilities. It does speak to, once patients are identified, that you put them on contact precautions, that there be a method to
You put on.
contact precautions, the isolation that Carol is. So there's different types of transmissible.
Are they put in isolation?
The recommendations are to do that, and that is the
The
community.
recommendation is.
Yes, the CDC recommendations for the guidelines are that.
Okay, so
Now,
this.
to add teeth to that, the Joint Commission, which does the accreditation process and is a CMS guarantor, does require, under their national patient safety goals, the use of contact precautions for multi-drug resistant organisms.
Okay.
Which includes
but
MRSA.
my real question is, what does DPH do in the state of California when a patient comes into a hospital, is admitted, and has MRSA? What is done? What are the regulations? What is done every single time, not just what is recommended by a federal?
Well, DPH wouldn't be in the process to do like every single encounter, but each hospital has to have policies and procedures in their infection prevention program and the community standard
Okay.
is to follow the CDC guidelines.
Okay.
I do know that there are exceptions out in the world, and they have
But
data.
excuse me for
I'm sorry.
interrupting. I feel real strongly about this, and I'm normally not quite so Greek about things. But it ought to be in the law and regulation that if somebody is admitted to the hospital with MRSA, it's not just recommended, but that the person is isolated so he or she cannot infect someone else. And that includes the 15% who are not reporting. It shouldn't just be, so I'm putting that out there real clear. That's something that is easy to do, and not just as a recommendation, but it has to be done. Was there anything else you wanted to say, Ms. Flood? Ms. Rogers, did you want to say something? Anyone else want to say something on this point? I have a question for Ms. Imholtz. What would it take to convince you that DPH is taking their enforcement role seriously with respect to the laws the legislature has passed in regard to hospital infections and to require greater public reporting of hospital infections?
Well, I think we want to see the regulations, all the required regulations written promptly. I know we saw a projected date of, I think, 2012, if I'm not mistaken. I know OAL is not within your control, and that can take a while, but it seems to me it shouldn't take a year to draft some of the regulations that have been required now for a couple of years. So prompt regulations, prompt surveys out in the field to check on the patient safety plans that each hospital is required to have, I think under SB 158, if I'm not mistaken. And something that may seem small, but since Consumers Union thinks the key to this all really is public access to information, it's fix the website to make it really clear and easy how to complain about a hospital, where to find that information about how to complain, and then where to find the reports by hospital about their rates, because the research shows that that's what really drives the improvement. That's not required by the law. It's not in any statute, but exactly.
I would agree 100%. Mr. Drown, I would ask you the same question. Anything you would add there in terms of what would it take for you to feel that DPH is seriously working on this?
Two things. One is a repeated public articulation by the leadership of why they think this is an important goal and why it's a high priority, and it's, a statewide education project on this. That is part of the role we see as the leader of the Department of Public Health. The other thing is something we learned from Dr. Ken Kaiser, who previously has been the Director of Healthcare Services here and was behind the whole quality initiative at the Veterans Hospitals. Get the data out. And the thing about it, let the numbers speak. And if the numbers speak in ways that aren't clear, then there's an incentive to clean the numbers up so that they do. But when the data's out there, then people can compare, and there's an incentive to make sure the numbers are as sharp as they can be. So public reporting and let the people know.
I like that. And the reporting, just as a corollary, the reporting has to be written in such a way that anyone could understand.
Like the mutual fund industry did.
What is being said.
Right.
Yes. So we will want to see that, nice and clear, easy to understand, accessible. Okay.
Senator Dahlquist, just real quick, I'm going to make a statement along those lines. I am on the HAI committee. I do chair the Public Reporting Committee subcommittee. I can tell you that the resources that have been hired with the legislative funding do not meet the requirements in what the public is asking for. I lead this committee, and the people that we're working with at the Department of Health are not qualified to build a website. They do not have the experience, and this has been very disappointing based on the fact that we know this legislation, a big piece of it, is let's share the information with the consumer. Today we have myself and one other member who's a victim putting together the website. We're not experts. We don't have the resources to do that. This is a priority that needs to be handled that way.
Ms. Moss, thank you. And if I understand correctly, earlier you said that DPH had all the resources that it needed. Are you saying that the resources could be allocated in a different fashion? And are you saying that there needs to be an expertise computer-wise for someone to be able to have the sophistication to build the kind of website that is needed, that resource is not available currently?
That's right. They have been given the funding and the positions. However, in looking at what's required, the capabilities are not today are not on staff.
Thank you. Ms. Billingsley, did you want to respond?
Yeah, Carol is correct. We do have that position. We have not filled that position. We're currently in a hiring freeze. We have developed that website by the 8 people who are currently there, who obviously do not have a lot of expertise in that particular area. So there is an opportunity there, and we'll be able to fill that position hopefully soon. We've been interviewing, and we'd like to, again, enhance the system with respect to the HAI program.
So how soon do you anticipate filling that position?
We aren't able to fill positions right now due to the hiring freeze.
Because it sounded like you said you hope to fill
Well, we
it
will
soon.
go ahead and have everyone interviewed and everything ready to go, so that, when the hiring freeze ends, we'll be able to go forward with the hiring. And it makes it difficult sometimes in order to promise a job in the future when you don't really know when the freeze will end.
We have a question, Mr. Hansel and I, on this one. You cannot contract?
We now can contract now that we have a budget. Prior to that, we could not
But
contract.
now you can.
Yes,
So
we
you
can.
could- you
That's a
could
great idea. We
So
definitely
you
should
could
look at that.
contract and have someone, so I know you've got fantastic volunteers, but also it would be really important to have somebody on staff whose main responsibility this would be.
Yes, we agree. Thank you.
Thank you. Okay. Well, we're doing good, doing well, rather. So now we will begin with the adverse event reporting. And thank you all for being here, and thank you for your honest comments. It will make a difference. Thank you very much. I'll introduce the second reactor panel. Of course, Ms. Billingsley is staying with us the whole time. Again, we will have Ms. Rogers and Ms. Imholtz. In addition, we will have Beth Capel representing Service Employees International Union. Welcome, Ms. Capel. And we will begin with Ms. Billingsley, who will have 10 minutes on the topic of the adverse event reporting. And then after she speaks for 10 minutes, we will have questions, Q&A for 15 minutes. And then after that, we'll have the reactor panel.
I believe my original testimony did cover the adverse events in terms of speaking to it at a fairly high level. So I would recommend that we go ahead and launch into the questions if that would be your desire.
That would be great. Thank you very much. Okay, I'll give you the bottom line first, and then we'll go into all the questions. DPH has not been actively enforcing requirements that hospitals report adverse events to the department within 5 days or within 24 hours if the event poses an ongoing urgent threat to patients, staff, or visitors. So my questions will revolve a lot around that core concept. So, Ms. Billingsley, you've told us that the department is aware of underreporting of adverse events by hospitals. However, the department does not appear to be targeting these hospitals for inspections or other enforcement actions. What is DPH doing to proactively identify hospitals that are failing to make reports?
Thank you. Nationwide, with the reporting of adverse events to many states, what they have found is that there is definitely an issue with underreporting. So this is not peculiar to the state of California. And I sit and participate on the National Quality Forum looking for ways to basically enhance reporting. We are seeing a pattern that's replicated in other states that just begin adverse event reporting by the fact that we've started with 900 events and have now on the first year and now moved to 1,546 events this last year. So what you tend to see over a period of time is an increase in reporting. We have aggressively issued, as I pointed out, the penalties for not reporting. By going ahead and issuing those. Some of the penalties range as high as $30,000 when we find that a hospital has not reported, and we have collected a sizable amount of money from that. But the important piece is that we are following up when we find an event or when someone reports late. We agree with the committee's earlier discussion regarding the use of OSHPD data, and we believe that we will immediately start to look at that with respect to tying hospital discharge data and information to the actual events. We have a pending contract with the University of California at Davis to conduct an independent analysis to verify that we have underreporting in California so that that information can be communicated to all providers. We have also, as I pointed out earlier, sent letters to each of the CEOs of hospitals asking them to attest to the fact that they have reported all of the adverse events that have occurred at their hospital, and to also indicate to us how they have gone about looking at their own data and information to conduct an assessment of that. This attestation statement is just going now to the non-reporters. On an annual basis, it will be sent to every single CEO. We also are looking to others for other feedback regarding other actions we can take. We will issue deficiencies when appropriate, and we will issue penalties for failure to report. But any other recommendations would indeed be welcome. Thank you.
Thank you. According to the data you've given us, only 53.6% of the department's investigations of adverse events involving a threat of immediate jeopardy to patients, staff, or visitors are concluded within the statutorily required 45-day time limit. So only slightly more than half. That's really pretty low. And that's within the 45 days that we gave, which I thought at the time was very generous to extend it to 45 days. What steps is the department taking to increase the number of investigations it completes on time?
Well, you can see from the information on the report that was given to you previously, in the first year, 65% exceeded the 45-day time frame, and this last year we reduced that to 30%. So in a situation in which we have not added additional staff, we have improved our performance in this particular area. With respect to the resource and staffing issues, the original budget change proposal that was submitted, and we were granted the funding for the health facility evaluators, assumed that we would receive 831 events. And so the staffing for that is actually was 21 health facility evaluator nurses to conduct the 800 events. Now, we've almost doubled that at this point in time. So we are definitely resource stretched. We have looked at job aids. We look at the criticality of an event to try to get as many events investigated at one hospital at any given point in time. And we have, again, stressed the overall importance of these investigations, again, because we do think that they are could be a clear indicator of systemic problems in California hospitals, and we believe it's important for us to get out there as soon as possible. So I think we're moving in the right direction with the resources that we have.
Going back to the first part of the hearing, which was on the hospital-acquired infections, it's clear to me that the department in that area certainly has the resources. I mean, you need to hire the person who has the expertise to do the website, but in that area, you do have the resources. And in this one, I'm still analyzing as we go. But I would ask, what steps are you taking to increase the number of investigations you can complete on time?
I think that
it's like, you know, what is, not to be dramatic.
What?
Not to be dramatic, but what is life worth? And you're making some progress in this area. The department is making some progress, but what else can be done? Because more needs to be done. Are you saying it's all in the hospitals? that they're just not doing their part?
Well, I think you're asking how much more can we as a team in licensing and certification do to be able to meet that 45-day time frame so we can conduct these investigations. What we have been looking at is we definitely look at the fact that if there's a potential for imminent danger, we are required to go out immediately, and we do so. And I think that the next piece of this is that the staff in the 15 different district offices have been directed to look at the seriousness of the events and, based upon that, go out and conduct adverse events. Based upon our interpretation of the language, there is a potential for us to not necessarily go on site and conduct an on-site investigation for each of these events. Approximately 40% of all of the events that are reported to licensing and certification as an adverse event are stage 3 and 4 pressure ulcers, which have been acquired upon admission. This has been a pretty strong lightning rod, I think, for California hospitals in terms of these huge numbers that have occurred. Now, these are not people who were admitted with pressure ulcers. These are people who acquired them during admissions.
Lots of times people who just aren't being turned.
In some cases it can be. In some cases the patient cannot be turned in rare circumstances. But again, this has really, I think, highlighted an issue which, people are responding to. There are some great programs that have been launched by California hospitals to look at this. Now, I think part of the discussion that we have had as a group is looking at our numbers, knowing people are going to report more this next year. And how can we use the limited resources that we do have to conduct these investigations. So we have been looking at developing a separate type of review for pressure ulcers that would not involve the on-site review process, which would decrease the amount of time that would be spent in travel, and then put the onus back on the hospital to basically not only report these, but provide the background information and the corrective action plan. We can then follow up on compliance and with the action plan when we do visit that hospital as a part of many of our other on-site visits, because we do conduct on-site visits for complaints, for unusual occurrences, and as we discussed previously, we'll be out there doing the patient safety licensing surveys. So we can follow up on compliance at that point in time.
Thank you.
So we are looking at that.
Thank you. And if I could just follow up, and then you're leaving. Do you want to ask something?
Ms. Rogers, do all hospitals belong to your organization?
Nearly all, yes.
So does the onus then fall on you to do more work with whatever it is that you do?
In relation to adverse events or pressure?
To everything.
Yeah,
to everything.
Absolutely. And as I talked about related to hospital-acquired infections, our regional associations that cover the entire state have patient safety collaboratives where they're working on foreign body retained after surgery. They're working on pressure ulcers. They're working on infections and falls and medication safety, surgical safety, a variety of different things that would fit into these adverse events, something we take very, very seriously.
Secondly, with all of the onset of everything, is this a new phenomenon, or is it just that it has come to the fore?
I think in recent years, and since the Institute of Medicine's reports of 10 plus years ago, talking about medical errors, talking about some of the causes for medical errors, I think that we're hearing more about it now. Certainly, hospitals are more aware than ever before of the problems that exist. We work all the time on system problems to ensure that these events don't happen in the future. And when there is an event that happens or something's reported that something nearly happened, we take that very seriously as well. The law requires us to do a root cause analysis and to look at the event and all of the contributing factors so we can put in place additional systems to make sure that that event isn't able to happen again sometime in the future.
But the phenomenon of MRSA that has risen to the fore, is that something that is new? Is that something that is just more prevalent? What?
MRSA it's my understanding that it is more prevalent now than it was in the past. We're seeing recent studies showing that it's more prevalent in the community than it is actually hospital acquired. but the multi-drug resistant organisms phenomena with the onset of the invent of antibiotics and the overuse of antibiotics in more recent decades, I think that's where we've seen a lot more of that than we did before.
Great questions. Thank you. And thank you for being here, Senator Negrete McLeod. I really appreciate it.
Got a flight.
Thanks, Senator. Okay.
Continuing on this topic, I have a request for the department, and that is to send us information on ways that the department will increase the number of investigations it can complete on time. Some related thoughts would be for the Hospital Association and the department, I would think there's a way using telemedicine that some of this work could be done more efficiently and more quickly. A question is, when you analyze the Never 27, Never 28 into what are the kinds of things happening, and this is a question both for the department and for CHA, what kind of training that is now not being done is the first question. What kind of training could be done statewide? And second, I would differentiate, because I think once in a while there are more problems when someone is absent and a temporary person is brought in. What kind of training does everyone have who comes in contact with a patient? And that means both someone who's temporary as well as those in permanent positions. If you could both address both of my comments, please.
In relation to the training and the orientation, all staff at the bedside need to go through both, have a basic level of competence, which part of that comes with their licensing category if they're a registered nurse, but there's also competencies about the specific care of the patients and the protocols of the patients on the particular unit that person would work. So there's the competency piece of it. There's also an orientation piece of it. Here's how we document on this unit. Here are the protocols. Here are the chains of command, those sorts of things. So it's sort of a two-pronged approach, if you will, that all staff would go through before they're able to care for patients.
And so you think, not to put words in your mouth, but you think everything is being done appropriately?
I think that as far as the training and the competence, yes. I think, Madam Chair, if I might, one of the things that has come out with the recent work on medical errors is that we have human beings who take care of our patients. I mean, that's our staff. That's what we do. And every human is capable of a mistake. It's the role of the hospital to try and, not to try, but to put in as many systems and as many stopgaps to prevent the error, to, in other words, make doing the right thing the easy thing. Sometimes that doesn't happen. I know that you've done significant work on the connector tubes between the IV tubes and the epidural tubes. It's still possible, because of the technology, that a nurse can put an IV medication into an epidural, and we've seen this. I find it interesting that when cars changed from leaded gasoline to unleaded gasoline, it didn't take very long at all. Actually, it took about that long for the cars to figure out, or the gas stations to figure out how to prevent me from ruining my car. The tubing that exists in the world, you can still connect the wrong tubing to the wrong tubing rather than physically have it being able to fit. So hospitals are working hard every day to put systems in place where we can prevent errors, and there are some things that are out of our control where it still is possible to put that wrong tube in the wrong error. Now, does that nurse need more training? Every nurse knows you're not supposed to put that tube in the other tube, but sometimes people make mistakes.
I appreciate it, Ms. Rogers, that you corrected yourself at one point when you said, we'll try to do X, Y, Z, and you changed it to we will do, because many years ago, the difference between the Boy Scout oath and the Girl Scout oath was, the Girl Scout oath was, I will try and do my best. The Boy Scout oath was, I will do my best. And there's a huge, words are powerful and they're important. So thank you for that. Okay. Another question. Are some hospitals underreporting the number of adverse events because they don't believe the definition of some of the events, that the definition is clear enough? For example, is it totally clear would a patient death within 24 hours for a patient who is otherwise healthy means for reporting purposes, is one example. If not, how is the department going to provide the additional clarification, and why has it not been done so before now?
From the very beginning of the reporting of adverse events, the hospital provider community has come back to us with a request for some clarity of some of the 27 never events from the National Quality Forum. Those are used nationwide by many states to report their events. We, in our discussions with the Hospital Association, and in recognition at the time that we did not have a regulations unit that was functional, nor did we have the staff at that point in time, we basically asked the Hospital Association to go ahead and go forward and help us with those definitions. We are now at an interesting point in time, I believe, having worked with the National Quality Forum that originally outlined the 27 never events. By July of this next year, there will be a new list of events. Some of them, I'm speculating here, but I believe some events will be removed and some new events will be added. So I think I bring this to your attention as an opportunity for all of us to look at this and to determine if this is a direction that we want to go, or we want to retain the list of events that we have now and further define some of them. We certainly cannot lessen the meaning of the event itself and the collection of the data and the enforcement action that is taken. And I think everybody agrees that that is the way the program is to be administered.
And Madam Chair, we would say that there's both over-reporting and under-reporting because of the lack of definitions. So it is true that these events were first coined by the National Quality Forum. They were originally called never events. Now they're called actually serious reportable events because there is an acknowledgement that some of these events, in fact, are not preventable. But the lack of definition of when surgery ends is very important in the retained foreign object. Is it with the first stitch to close the wound? Is it with the last stitch to close the wound? Is it when the patient goes to the recovery room? And we can find national organizations that use any of those definitions. So we are hopeful that as the department moves forward with regulations dealing with immediate jeopardy, that with that we can codify the directions or the definitions for adverse events.
I have a question, Ms. Rogers, and we'll go back to Ms. Billingsley. I understand that the California Hospital Association doesn't use a checklist to make sure surgical implements aren't left in someone. Is that accurate?
Well, the California Hospital is a checklist to make sure every hospital has a virtually every hospital uses a surgical checklist and absolutely has procedures to count the sponges, to count the instruments that they use.
So that is something, is that devised? I guess I'm trying to figure out if my bill was really completely implemented. In other words, if I'm going to have an operation, if my granddaughter's going to have an operation, before the surgical team starts operating on her, does the team meet, the team, the doctors, the nurses, everyone there, and they make sure they have a list? And this list, is it devised at the local level, or who actually creates the list. So I guess what I'm asking, too, is it at the option of each hospital to figure out what should be on a checklist, or do you, the CHA, have a recommended list, or how does this all work?
Well, related to surgical safety, the World
Yes.
Health Organization has developed a list.
Is that what you use?
Most hospitals use a modified version of it, just to get technical on you. It's a nationwide checklist. One of the elements is pulse oximetry, which in other countries is sort of new to them. For us, we have a pulse oximeter on nearly every patient that's in our hospital. So most hospitals use a modified version of the WHO surgical checklist. But yes, you're absolutely right. The surgeon, the nursing staff, the support staff, and sometimes if the patient's awake, talk about what the procedure is, identify that there is the right patient, and that we're doing the right procedure. And then at the end of the surgery, there's absolutely a sponge count. Now, sometimes a sponge is left in if the sponge is cut in half. You know, sometimes mistakes are made and the count is incorrect, even if the staff felt like they counted it correct.
On the points that we just talked about, I still need to really understand, does each hospital develop its own
Well,
checklist?
the joint-
is the first question. And then the second piece is, I understand that something some hospitals do, and I'm wondering if it's something all hospitals do, where the team actually meets before the surgery, because sometimes you have different people on the team who have not worked together before, and it's important for them to have some time with each other before they actually operate.
That's a requirement of the Joint Commission. Absolutely, every hospital
So
should
are
be
both
doing
of
that.
those done on? Are both of those on a checklist for every single all of the hospitals, or does each hospital determine what's on the checklist? It's really kind of like one way or the other. Either there's
Each hospital has the opportunity to put whatever they want on the checklist, but because an international checklist exists, actually, my association actually recommends, encourages hospitals to use it. That's predominantly what people use. The Joint Commission, when they come out to look at hospitals, they're the deeming authority for CMS. They look at what kind of surgical safety programs do hospitals have in place, and this includes a checklist. So there's oversight in that way that they're looking at the checklist. I don't know from the department's perspective if that's something that they look at in relation to surgical safety. It probably would be if they were investigating a foreign body retained after surgery or a surgical mishap.
Eventually I will be asking that question of Ms. Billingsley. It sounds like there is a list that CHA recommends. It also sounds like it's not mandatory for a hospital to follow that list. I can understand where a hospital might want to add to the list, but I also think there ought to be the basic things mandatory that need to be on that list, and if a hospital chooses to go beyond that, that would be fine too. But it sounds like there's not a mandatory checklist.
To be honest,
you make a recommendation.
To be honest with you, on the joint, I'm not an expert on the Joint Commission requirement of exactly what's on the surgical safety checklist,
Okay.
but I can find that out for you.
Thank you, Ms. Rogers. I would appreciate that. And Ms. Billingsley, one reason I would be really interested in understanding then, for us to understand what the other one of us understands here, is that that's an evaluation tool, and that plays a role in these adverse events. I mean, if there are hospitals that are not really using a checklist, and they're also not reporting, or they're having a lot of adverse events, it sounds to me that something in terms of oversight would need to be done, and I would ask the department, DPH, to clarify what is mandatory in terms of the checklist and how that relates to adverse events in hospitals, and also is there a correlation between hospitals that don't have a specific checklist who are not reporting?
All right, let's This is a big subject and an important subject for us, and one that I thank you for bringing to our attention. Of the 4,296 events that have been reported to us, 676 of them are for the retention of a foreign object. And we look to the hospital to have a policy and procedure in place for their checklist that they follow. And there are, and that they conduct their surgeries to prevent the retention of a foreign object. So any finding that we have and deficiency is related to the actions on the part of the hospital. So basically the answer to the question that I see from my experience having toured some hospitals is there can be some variation between how certain things are done.
There's no minimum list. I heard you
but
say...
I'm just saying that there can be a variation that a hospital can take with respect to that list. But on the other hand, what I've also seen is that hospital systems have made an effort to eliminate the differences between how Hospital A was doing it and how Hospital B was doing it. So to basically eliminate any potential for that variation.
If I may add here, I also heard you say that you look to hospitals doing this. And my question is, what is the requirement? Do you just recommend, or do you, and that is looking to, or do you say, this is what needs to be done, and we will judge you accordingly?
The looking to how you're doing the job as a hospital is we don't have the authority to mandate what they have on that list, but we have the authority to look at what their list is and how they're performing against it. So we look at their policies and procedures and say, are you executing what you have written down to be the protocol that you're going to use in this case? And if they do not follow the protocol, then they are issued a deficiency. Now, one other item I'd like to bring to your attention.
Before we go there, though, to bring closure to it so then we can go on. So then is CHA then responsible? Or is it ultimately the individual hospital that's responsible for what's on their checklist? And what I'm saying is, to me, there are a minimum number of things that ought to be on that checklist, and not to have that just is not good enough.
Madam Chair, because this isn't my area of expertise, I'd like to get for you what the Joint Commission requires, what they mandate in order to receive funding from CMS. It's a multi-page document. I know the checklist itself is not multi-page because let me get that with you, to you, and then maybe we can continue this conversation. I think that there is a minimum standard that exists because the Joint Commission has certain requirements in order to be accredited, can't be accredited without meeting those requirements. Does every list in the state look the same? The answer is no. But do they all have a minimum level of something? I would feel fairly certain that they do.
Okay. And on that point, and then we'll move forward, I'm hearing a lot of we think something is being done, but we're not really sure. I don't think it's good enough just to judge a hospital according to what it thinks is appropriate. I think it's important to judge a hospital according to what the public thinks is important. So in this process, it'll be nice to find out what a world organization or somebody else thinks, but what I really want to know as a yaya, as a grandmother, is what does the hospital have to do? What kind of checklist do they really have? And I'm glad for them to individuate and go beyond a basic list, but I want to be sure that, and is it CHA that monitors this? Who actually, and I think hospitals for the most part do a really good job, but when you have 15% that don't, that's a whole lot of people. in that 15%. So I want to know, when I say I'm speaking for the public, I want to know what's on the checklist and really what's not. I think California's been a leader in this area. I mean, I've seen lately on Good Morning America in the news that more is being done on the federal level on this point. But it's time now that we really address how we can really correct the situation, and we're going in the right direction. And I appreciate all that the department does and that CHA does. But there's still a lot, I think, that needs to be done. And to really problem solve, we really need to know what is really required, how things can be done differently, and how hospitals can do things differently also. So thank you very much for putting up with my questions. Ms. Billingsley, we've probably had enough questions on this point. So on the, but if not, you could go on.
I do want to add just one thing, just as a reminder. The monies that are collected through the administrative penalties go into a quality improvement fund, and I have come back to the Budget Committee to ask sometimes for an appropriation. So we did seek an appropriation for $800,000 to look at the retention of a foreign object issue in California statewide. And we've talked to, we are just now that we have a budget, we actually will have the monies, and we'll be bringing together a consortium of individuals representing many stakeholders to look at how these funds can best be used with a quality improvement program statewide, to look at some standardization and consistency that we believe will help reduce the number of retained foreign objects.
Senator, may I just ask you?
Yes, and I still have Ms. Rogers, Ms. Imholtz, Ms. Capel on the list here to speak. So at this point, I think I'll be quiet. And Ms. Rogers, was there anything you wanted to add?
I think that.
And then we'll go on to the others after you.
I think that we've talked about most everything that I had in my prepared remarks, only to say that on the surgical checklist, as the department asks hospitals about the mistakes and the challenges that they've had through the licensing survey, they go back and look at the policies and procedures. I would assume that when the department looks at a surgical safety policy and procedure, if it were missing something basic like identifying the patient, identifying the procedure that's going to be happening, the department would be in a position where they could cite that hospital and give that hospital a deficiency if those big standardized things that you're talking about were not in fact in their policy or on their checklist.
Thank you. You said it better than I could, and yes, there needs to be some accountability here, and I think the department needs to figure out a way to do that. I think the rate will improve immensely when that is done. Thank you. So that's it. Thank you very much. Okay, Ms. Imholtz.
Yes. Thank you, Senator. The department seems to be making greater headway, I would say, in prioritizing the implementation of the adverse event laws than in the hospital-acquired infection ones. I was piping in a minute ago because when Ms. Billingsley mentioned a working group, I don't know if that's the word you used, on retention of foreign objects, I wanted to make a pitch that there be consumer involvement in that committee as well. Another one on hospital-acquired infections has been ongoing for a couple of years now without any consumer representation, so we would appreciate the involvement of consumers in that one. The Department for Adverse Events is issuing fines for practices found to jeopardize patient safety and for failure to report within the statutory timeframes, and most importantly from our perspective as well, is widely publicizing the actions that the department is taking. And this sends the kind of message that we really just need to get out there so that hospitals are aware that there is a regulator out there that's going to be active actively involved. I was going to touch on the underreporting issue. We've said a lot about it. I'm delighted to hear Ms. Billingsley say that they agree with the idea about looking at the OSHPD data. It's a rich database. Even if the definitions aren't exactly the same as the ones under 1301, there's enough there, I think, that will help you not just look at it, but help you target where there are gross disparities between billing data and adverse event reporting data. So terrific. The other point I wanted to raise is a general one with a couple specifics about public access to data. It's a cornerstone of our belief, and I know the Little Hoover Commission's as well, that putting this kind of information out in the public realm really spurs improvement. And we think that the Health Facilities Consumer Information System on the DPH website is a good beginning. All the detailed survey information is up there now. I would say, though, it's difficult to find and decipher. So we give them all credit for posting it and are glad to see it there. It is tough to get through, and so if there's a way that we can actually explain the codes and just make that more user-friendly, that would be really terrific and important, I think. The statute does require the posting of hospital-specific information in a readily accessible way by 2015, but there's nothing that precludes the department from doing it earlier. And if they could get to that, it's a long way off to 2015. That would really be terrific, and I think they've been great about providing upon request, as the statute requires, providing the information to groups, and consumers unions, one of them, has benefited from that. So that's great. But for the general public that doesn't know how to do that, making that more readily available before 2015 on the website would be terrific and a strong motivator, I think, for improvement. The culture of safety question, we've been circling all around that today, and SB 158 really had a number of steps that were meant to address that, requiring creation of a patient safety plan, committees and internal reporting systems to allow anyone to report an adverse event, and as well hospitals now being required to notify a patient when they've been the victim of an adverse event. The department's been authorized for a couple years now to inspect for that, but it appears they've just begun to do so last month. More needs to be done on that, and to get that up and running. I guess the patient safety licensing survey will help them do that. But we also understand that the department's position has been that survey information is confidential, that surveys remain confidential, as I understand it. So if that's the case, it keeps a lot of, that's not the case.
We'll ask when you're through.
Okay. If that is the case, it would keep a lot of important information from the public, and we hope that's not it. Without the public accountability aspect, we appreciate all the prevention steps and the patient safety organizations that the Hospital Association and others are involved in, but all those efforts are confidential. That's private information.
Was there a closing comment you wanted to make?
Yes, just without the public accountability aspect, the hospital, for the hospital policy and performances, the preventable harm we think will still happen, and the public disclosure is really important.
Thank you.
Thank you.
And Ms. Billingsley will just ask now, is the survey information confidential?
The survey file...
How's it used?
No. There are components of the file, which are the investigator notes, that are confidential. The survey report itself is always available to the public once it's been issued to the provider, even before the plan of correction is available.
So the notes are confidential?
The notes are confidential.
So what's the fine line?
And in the notes have been the notes of confirming that they've spoken with the person, and the individual who was subject of an adverse event has been informed. We have modified our practice through this discussion, and all 2567 survey reports will indicate whether or not the patient has been informed. We have issued historically since 2007 deficiencies for not informing the patient, but we have not put it in the survey report. So now anyone who looks at the survey report that is posted on HCFAS, available to look at, that information will be there.
So what kind of information is posted? I mean, I'm hearing
we do not.
I'm hearing that the confidential notes are not posted.
Correct.
But that
the survey.
But you're saying that the survey findings. So I guess what I'm asking is, what's the translation? How much real information is posted? What kind of real information is posted?
In the 2567, it will state whether or not the hospital informed the patient of an adverse event or not. If they did not inform the patient, the hospital would be issued a deficiency for not following the law.
But there's not any information of what the adverse event is?
No, it's in the report.
It's in the
that
report.
Describes, in the 2567 is the survey finding for that particular investigation for that adverse event.
And then how much of that is really put on a website where the public can see?
That is available. Well, we do not post all of the substantiated 2567s for adverse events yet. As you know, that's 2015. Every effort is being made right now to move forward and to secure, go through all the processes so that we can post all substantiated adverse events prior to that deadline.
So what is the department's goal for really posting everything?
For posting everything will definitely be a bit of a challenge, but because of the volume that we do have. Right now we are working. Now that the budget has passed, we have our first level of funding to be able to start to build the process to go ahead and post all substantiated adverse events. So according to what is written in law, we will abide by that and post the information.
Thank you very much.
I do not have an exact date.
Thank you. Okay, Ms. Capel.
Beth Capel on behalf of the Service Employees International Union. We represent hospital workers, from doctors and nurses and housekeepers and clerk, every kind of worker there is in healthcare who's involved in minimizing adverse events. We also represent the public employees at the Department of Public Health and at the LA County Department of Public Health who survey hospitals, so we see this from both sides. And I want to begin by noting how troubled we are by the furloughs and the freezes on these positions, which are, after all, fee-supported and special funded. There is no way that a public employee can do their job if they've been furloughed on that day. So I want to begin with that clear statement of our dismay with the circumstance that our employees, our members have faced over the last several years. We've talked a lot today about deficiencies. A deficiency is roughly a parking ticket, and just as parking tickets are sometimes appropriate, deficiencies are sometimes appropriate. Our members report repeatedly that plans of correction are never complied with and that they would not fix the problem. Madam Chair, you were exactly right that following the protocol may not be sufficient, that often hospitals have a protocol but don't observe it, and even if they have a protocol, it may not be sufficient to fix the problem. The back and forth you were engaged in with respect to the surgical checklist is interesting, but after all, surgery incidents associated with surgery are only one type of adverse events. There are many others. And to look beyond surgery, where there have been checklists for many years, we would ask whether there are checklists associated with reducing the other adverse events. And although JCAHO accredits some hospitals in California, it does not accredit all. It is the responsibility of the Department of Public Health to enforce the requirements of CMS, not of JCAHO. With respect to underreporting, we are pleased to hear that the department will be looking at the OSHPD data. We would encourage a much more intensive use of both the OSHPD data and the Medicare and Medi-Cal claims data for each hospital prior to inspection, for each change of ownership, and indeed in response to each adverse event complaint. And I want to give you a few examples of why. An analysis done in 2009 using OSHPD hospital discharge data found over 300,000 patient days attributable to adverse events for just 4 adverse events: for an object air embolism, blood incompatibility, and falls and trauma. That analysis also found over 2 million patient days attributable to catheter-associated urinary tract infections. You have not heard a single set of numbers today that's anywhere on that scale. An analysis done by SEIU found that 5 hospitals operated by Prime Healthcare had the highest rates of septicemia or blood infections, 5 of the 6 highest rates in the country, and that the company-wide rate was 4.5 standard deviations above the mean. This is the kind of data that's available from Medicare claims and from the OSHPD data. Similarly, hospitals reported in adverse events about 1,000 stage 3 and stage 4 pressure ulcers to CDPH, but for the same year, there were 117,000 claims for skin ulcers reported to OSHPD. Now, we recognize that there's not perfect compatibility here, the definitions are not identical, that not every claim for a skin ulcer is a stage 3 or stage 4. But after all, stage 1 is not the sort of thing that would result in a payment claim. We think these are very gaping numbers, and they raise very serious questions in our mind about the magnitude of underreporting, as well as the need for the department to use the OSHPD data and the Medicare and Medicaid claims data effectively when they're doing licensing surveys, when they're doing changes of ownerships, and when they're responding to a complaint of an adverse event. Thank you.
I'd like to continue with Ms. Capel. I think you've talked about this, but if you have any other suggestions here. The question is written was, has anybody explored in a rigorous way the potential for using hospital data that is reported to OSHPD to identify hospitals with high numbers of infections and adverse events that you're aware of? Should this be more fully explored? What's your thoughts in this area? Because it certainly seems that there needs to be more. I mean, there's lots of information, but not one person is getting to look at all of it in order to set really good regulations.
We are pleased to learn today that the department has begun the process of looking at that. We really think that that cannot be a one-time event, that really every time, and we're not suggesting it is, we're learning today as we go on this, but that really each surveyor, when they go out to a hospital, ought to be equipped with a profile of that hospital from the data that's available that says, here you have a hospital that has whatever the number is of pressure sores reported as claims on the OSHPD data. They reported 25, I'm making it up, whatever it was, 225. Stage 3 pressure ulcers, what's going on there? It should be part of the survey. It should be part of what they look at. We know, and we commend the department for the progress that we've made. We think part of our job is to say, we're part of the way down the trail, but we've got more work to do here. And so I think that we think that's important. We also think it's important that they look at this before they approve a change of ownership. They have the authority under existing law to check these things and also to check with other departments for violations of the law, for example, the Department of Managed Health Care with respect to balance billing. And so there are other things that they can look at under existing law. We would, commend to you a more extensive use of this information.
I'd like both Ms. Billingsley and Ms. Rogers to comment on some of the things Ms. Capel stated, including the part about what occurs when there's a change of ownership. So I guess that's more. But the other pieces also.
When you look at the research and you compare coded data with the actual clinical data that comes out of a chart, they're often different. And so I would question the validity of data looking at that many pressure ulcers having been reported, how many of them actually end up in the serious levels of the stage 3s and stage 4s, how many of them were present on admission. I think, I think that there are challenges to the methodology, and I think we'd like to hear more about it.
But that speaks to a couple things. Well, the main thing is when a person is admitted to a hospital, he or she may have come from a nursing home or some other kind of environment, and so what kind of I don't know, the evaluation is done of that patient so that you know, just like you check them for MRSA when they first enter. So what kind of health and what kind of condition is that patient in? And then you have something to evaluate against. So what is really being done in that area of admissions?
There are national standards of things that need to be documented, that need to be looked at. Part of the challenge, frankly, is how do we translate that from the chart to what the coder puts in the record sometimes.
So that speaks to training of the coder, for starters.
Sometimes it speaks, frankly, to the training of the physicians who are the documenters.
Oh, okay.
So we can, they can better understand if they write high potassium, the coder cannot write hyperkalemia as a diagnosis. The physician has to write hyperkalemia, not just high potassium. And so there are thousands of those.
So there's some kind of training that could be involved in this area.
Madam Chair, if I might.
Ms. Capel.
All OSHPD data is hospital self-reported data that has no auditing done of it. There's no check. It's just whatever the hospital says. And there's a field audit. There's what's called a desk audit where they simply look at the data. I think to commend to you that it is time to work with OSHPD as well and to bring OSHPD together with licensing and certification to bring the data into the 21st century so that it allows accurate reporting of adverse events, so that they have capacity to audit, and frankly to get to our next panel so that you can actually determine compliance with the nurse ratios from the data.
I would agree. It just seems almost wasteful in what is almost 2011 that there's a lot of data out there, but there's just not one entity that is analyzing and using it for the benefit of the public. And we're all good people here, and so we need to figure out ways, and that's going to have to include OSHPD being at the table also. Ms. Capel, was there anything else you wanted to say? Okay. Is there any comment anyone else would like to make as part of this reactor panel? Nope. Okay.
I'm sorry. I apologize for doing this so late. I did want to clarify some other information that has just been provided to me because I wasn't 100% sure as to the date. We have been, as you know, developing that regulations unit, and we have sent a note out that there will be a public hearing held this next month regarding the regulations to clarify the adverse events. So regardless of the fact that there may be an opportunity to look at adverse events and the list of adverse events going forward, the department is taking action and having a public notice. Thank you.
In light of the time, I think we will go on to the last panel, and I want to thank all of you for the good comments. Thank you very much. Okay. For our last panel, we will focus on nurse staffing ratios. Again, we will have testimony from DPH, followed by questions and answers. Then we will hear from our last reactor panel, which will consist of Debbie Rogers from the California Hospital Association, Kelly Green, welcome, from the California Nurses Association, Beth Capel, on behalf of the Service Employees International Union. So thank you all for being here, and Ms. Billingsley will begin with your testimony.
Again, I covered that in the previous overview, so we can go ahead and move directly to questions.
Thank you. Okay, questions for Ms. Billingsley. You've told us that DPH only looks at a hospital staffing ratio if it determines that the hospital has quality of care problems and does not routinely inspect for hospitals' compliance with them. In essence, that's saying you wait until patients are harmed before you check the staffing to see if it's a problem. It seems to me that the legislature's intent in enacting AB 394, which I voted for back in the Assembly, was to ensure that hospitals consistently meet these ratios due to the evidence that better staffing enhances patient safety and produces better outcomes for patients. So what is your reaction to this? About being proactive versus...
Well, I do not believe that that I'd like to leave this hearing with the impression that licensing and certification would ever wait for something to happen.
Okay.
I believe that we do conduct timely investigations of any allegation or complaint regarding incorrect staff ratios. We finished an investigation just a little while ago at UC Davis that took just on site, and part of it over 250 staff hours, and issued deficiencies and substantiated situations that didn't rise to the level of a violation. And so we conduct a very thorough analysis of staff ratios, look at a multitude of records, conduct medical record review and interviews, and follow up diligently when there's any question regarding the lack of adherence to the staff ratios.
I wasn't sure. Did you go into that situation? Was it...
We responded to a complaint.
But you
at
were
UC
responding to a
Davis.
complaint.
We responded to a complaint.
My question really is, I know that you respond to complaints, but my question is, is the department being proactive and checking on its own to see whether a hospital meets its patient to staff ratio? I'm dyslexic, so staff to patient ratio.
We have not incorporated that into the patient safety licensing survey yet. There are other areas besides the 100 mandates that I spoke of today that will be incorporated. This is the first phase of a revision of the hospital survey tool, and we will be looking at all other mandates that have taken place that we currently are not looking at, but are responding to, I think, in a very timely manner with respect to the complaints. So this patient safety licensing survey will be expanded over periods of time to take into account other types of regulations or state standards that should be surveyed too. So I believe that this one has the potential for us to certainly look at.
Thank you. So, as I also believe it has the potential, more than the potential to be included, what would be DPH's timeline on adopting regulations that would say that DPH would proactively check hospitals to see if they were meeting the staff-to-patient ratio?
Well, having been with the state now for 4 years, I think the regulatory process is much slower than a legislative solution. So I think that, based upon the timeline for that, I think that needs to probably be considered as to where we should go with that.
Okay. Then I am making the request of the department. I am making the request of DPH to include in their material that DPH should proactively check to see if hospitals are meeting their staff-to-patient ratio.
Certainly.
Thank you. Okay. And in my request, I would also like to add that not only should it be proactive in seeing that hospitals implement the staff-to-patient ratio, but also that it should be done routinely to see if the hospital is in compliance. So what I'm looking for there is, how often. I know that if a complaint comes in, you go out and check it. But I'm also asking that the department do this proactively and routinely, so that if you go out one time, it doesn't mean that for the next 10 years you don't go out again.
Right. Well, I understand you're looking at the frequency as well.
Yes. Thank you very much. Okay. Okay, you've also indicated that DPH has only issued 2 administrative penalties associated with the 456 violations of nurse staffing ratios. That's a very low number and low percentage, assuming at least some of the violations are for chronic problems that may have occurred over a long period of time and occurred in several units of the hospital. Does that mean the department doesn't view most violations as anything to be concerned about from a patient safety point of view? What does that small percentage really mean?
Let me go ahead and clarify,
please,
this, if I could. So basically, we have issued a total of 465 deficiencies to 167 hospitals, and we've issued 2 administrative penalties that within that, the administrative penalty, the non-adherence to staff ratios was a contributor to what took place that resulted in an administrative penalty. As you know, in the absence of regulations to define an administrative penalty, the only definition we currently have is that it must meet the criteria for a definition of an immediate jeopardy. And immediate jeopardy, again, means a situation in which the licensee's non-compliance with one or more requirements of licensure has caused or is likely to cause serious injury or death to the patient. So we can only issue an administrative penalty when it meets that specific criteria. In the absence of that, we issue deficiencies.
Okay. I think we'll begin with the reactor panel. Ms. Rogers, the Hospital Association.
Thank you, Madam Chair and members. CHA has long opposed mandatory staffing ratios in that it doesn't take into consideration the needs of the patient or the experience and education of the providers at the bedside. Having said that, it is the law. Hospitals try hard, and I use the word try intentionally, to meet the staffing ratios every day. I'm happy to note that we are now 46th in the nation as far as the number of registered nurses per capita. We used to be 50, so we're going in the right direction. But there are not enough nurses to meet this requirement, and I know that my colleague, Ms. Capel, will probably disagree with me on that. We feel that staffing ratios, and I can speak from personal experience because I've worked as an emergency department nurse under ratios and not under ratios. With the mandated staffing ratios, our patients often stay in the emergency department because you can't take them upstairs because there's not an additional nurse upstairs to care for them. Hospitals staff according to their historic patterns. So we know as an emergency department nurse, Saturday night is really busy, and you know historically what that census is going to look like, and you staff appropriately for it. But when you can't move patients upstairs because they also are staffing on a historic basis from the number of patients that they usually have, it can clog up the emergency department, and then it decreases the throughput. Adding complexity onto that, California has significant break and meal rules where meeting the at all times requirement for the staffing ratios is also a challenge. Many hospitals will hire what we call a break nurse who comes on, toward the beginning of the shift and breaks and gives lunch to all the nurses in a row so everybody gets to have a break and have lunch, which we absolutely support. But how that actually actually gets operationalized is within about 45 minutes of coming on shift, the first nurse is asked to take a break because of the way that the meal and break periods laws are arranged. So we think that this law is a challenge. We're trying hard to meet it, but there are times where it may not always happen. It is interesting to note when you look at the literature and you look at the nursing sensitive quality indicators like hospital-acquired pressure ulcers and falls, there is no difference before the ratios and after the ratios, and there have been studies that have shown or that are showing that we don't know that there's a better quality of care now because of the ratios or not.
Thank you. Ms. Green with California Nurses Association.
Thank you, Madam Chair. I'm Kelly Green with the California Nurses Association. We represent over 86,000 registered nurses throughout the state of California. I appreciate the opportunity to participate on the panel. We appreciate the comments from Ms. Rogers. We respectfully disagree in many respects. As she stated, despite the challenges that she has just stated, the ratios are the law, and we expect them to be adhered to, and we expect them to be enforced. The premise of nurse-to-patient ratios is simple. By establishing minimum staffing standards, nurses are afforded a more manageable patient assignment and are better able to respond to patient needs. It's the simple premise of nurse-to-patient ratios. We also know that non-compliance with staffing ratios can be dangerous and deadly to patients. We're aware of many cases in which patients have been harmed, for example, by medication errors, by falls, or other preventable actions when nurses are assigned patient loads that exceed the minimum staffing requirements. There's also a growing number of research studies that do demonstrate a positive correlation between quality of care and positive patient outcomes that are a result of nurse-to-patient ratios. The most recent one is a study led by Linda Aiken that was a professor at the University of Pennsylvania that demonstrated, based on California standards, we do see positive patient outcomes, and we also see better nurse retention as well. With regard to enforcement, we do appreciate the complaint that Ms. Billingsley rose, which I believe is a result of a complaint submitted to the department by our organization. And we would like to commend them on the thorough investigation that they did on that complaint. It did reveal systemic problems with regards to noncompliance at that particular facility with nurse-to-patient ratios. We also are pleased to hear that routine inspections of staffing is being considered to be incorporated into the patient safety licensing survey. We would have liked to have seen that in this first issuance of the survey. According to DPH and in the responses provided to the committee, hospitals have been cited for staffing violations. 167 hospitals have been cited. That's roughly about 40% of our state's hospitals. We think that that certainly demonstrates a systemic problem with noncompliance and does provide the foundation for the need to do routine inspections. We also think, with regard to the tools and authority that the department could use to enhance its enforcement efforts, to perhaps consider going down the road of looking into the use of administrative fines as a deterrent to and a penalty for noncompliance with ratios. It's something that's been discussed today and something we certainly would support as far as consequences for noncompliance with the law. We also, if I may echo Ms. Capel's comments on the furloughs, we know that the department needs its staff ready and available to respond to complaints in a timely fashion, to conduct investigations. We are very dismayed with the imposition of furloughs, particularly on this program, which is funded by fees. It doesn't save the state money, and instead it just diverts staff time away from investigations, and it puts patient safety at additional risk. Lastly, Madam Chair, if I may, the last question that you had posed prior to today's hearing to the reaction panel was why we continue to hear stories of patients harmed by the failure of hospitals to meet nurse-to-patient ratios. And from our perspective, we think that there are a number of factors that contribute to that. For example, we believe that there needs to be continued recognition that the ratios provide a minimum standard and that staffing must be done according to patient acuity. Even if staffing is set at a point to meet the numbers of the ratio, if acuity of patients change, there needs to be response to that. We can't simply ask nurses or any other healthcare personnel, in fact, to have a patient load that's too high and that puts patient care in jeopardy and the patient in jeopardy. We also do believe that adequate coverage is necessary during meal and break periods. The regulations are clear. The department has interpreted the regulations appropriately, that ratios apply at all times. If a nurse goes on a meal or break, that doesn't mean that the ratios should not be adhered to during that period. And also, we do think that the hospitals and perhaps the department can look a little further into competency validation of nurses and making sure that nurses who are brought in to shore up staffing levels are properly oriented and that they are competent to provide care on that particular unit that they're coming to provide coverage for. So we think that with judicious enforcement, these issues that lead to noncompliance can be abated. Thank you.
Thank you. Ms. Capel?
Beth Capel, on behalf of the Service Employees International Union, we appreciate the opportunity to testify. We, too, represent tens of thousands of registered nurses here in California and across the country. I want to turn most of my time over to one of those nurses in just a moment, but 2 points. As someone who developed our ratio proposal, I remember well reading the tens of thousands of comments from registered nurses across California about the patient deaths that occurred because of inadequate staffing in California hospitals. Second, with respect to meal and break periods, that has been the law in California, I believe, since Hiram Johnson was governor. The fact that only a decade ago were penalties imposed that caused the hospitals to finally begin to comply with the law is no excuse for their failure to comply previously. The law, the ratios were always plainly at all times. The hospitals, in a misguided effort to delay implementation, challenged that through litigation. We are dismayed that the law that you authored, Madam Chair, that passed in 2006 that required enforcement of California law as a result of that 2005 hearing that you chaired still does not include the ratios in the routine licensing surveys, and we would hope that that would soon be corrected. I want to turn most of the rest of my time over to Donna Zagatti, who is one of our nurses, who will speak briefly to her experience with one hospital, Riverside Community Hospital.
Thank you and welcome. And unfortunately, we only have 90 seconds left on.
That's fine. Well,
yes.
Good afternoon. And again, my name is Donna Zagatti. I'm a registered nurse, and I work for SEIU Local 121 RN. I work with the RNs at Riverside Community Hospital, which is a large nonprofit, for-profit, sorry. Here's a stack of over 80 non-compliance for this particular one hospital, Riverside Community Hospital, that I personally filed between January and September of this year. These complaints are typical of what these nurses have observed. Management does not plan for admissions to these units during a shift, basing staffing on the number of patients at the beginning of the shift, staffing by numbers, not acuity. Ratios are routinely and repeated violations on these units. The requirements that the ratios applied at all time include meal periods and breaks. They are all ignored. Some units even start out of compliance. Lack of adequate support staff is constant, recurring complaint. This is what happens when we file these complaints. First, we get a letter from CDPH acknowledging the complaint. Then we get a letter from CDPH, says the complaint has been substantiated, validated. Then we can request a form, the CMS 2567. Nothing happens. Nothing. The hospital has continued month after month to violate the law in precisely the same way it was violating the law before. Nothing has changed. If the hospital has a plan of correction, either it's ignored that plan of correction or the plan of correction would not fix the problem, or both. If CDPH is following up, we have no way of telling. That's just not right. What is the point of the ratios if the hospitals can violate them with no consequences? Bottom line, what about the plan of correction? How do we enforce it? Thank you, Madam Chair.
Tell me your name again.
Donna Zagatti, S-I-G-A-T-Y.
Because I think your comments, Donna, go to the heart of what I will be asking next.
Thank you.
The question would be for Ms. Capel, and or Donna could answer it, Ms. Siggety.
Yes.
Either one could answer it, and the same question for Ms. Green. And that speaks to what Ms. Siggety just said, and that is for each of your respective organizations, whether it be CNA or SEIU, have you compiled the complaints regarding understaffing to determine how many represent serious chronic understaffing issues, and which hospitals or systems seem to get the most complaints? Do you have all that information?
I apologize, Madam Chair. I do not have that information here today. I can speak strictly on anecdotal evidence that's given to me from nurses who are our members, who do who do express to our organization that violations of staffing ratios is fairly systemic. And I can certainly try to work with our organization to see if we can pull together some of that data that you're requesting based on complaints that our organization has filed. And any other type of information that we have from the members who are in the hospitals.
Thank you.
Madam Chair, this is one example of a hospital where we tried to make sure that the ratios were enforced. We have other examples where we have been able to work with management through the collective bargaining process to achieve enforcement of the ratios. But frankly, it shouldn't take we shouldn't have to rely on the collective bargaining process to enforce state law. We're proud when we're able to do that for our members and for their patients, but it's the law, it's not a suggestion.
I would agree that it is the law and it should not have to be negotiated. I also think it would be helpful for us to have the actual data rather than just anecdotal, so we can really look at the information and to work with CHA to understand who is really not following the law and how we must deal with that.
Madam Chair, we have asked the leaders of our Nurse Alliance to do that for the hospitals that we represent. Every one of these, as Donna says, every one of these is a validated complaint for a single hospital. Yet nothing, all of this, yet nothing has changed. And so we also have instances in which our nurses have tried to file complaints and have been told by the CDPH staff that they do not have the capacity to come out and check them. And that's also, we know that they've made a lot of progress in improving enforcement, and we respect that. But that's also troubling, and frankly, it discourages people from complaining. And finally, it is not our job to survey every hospital in California. It's, we are doing our best to represent our members and to bring to your attention, and the patients they care for, bring to your attention these problems. But we don't represent nurses in every hospital as much as we'd like to.
Thank you, but I would say between your two organizations, you represent a lot of nurses, and that there are points where organizations need to work together for the greater good of solving the problem. Ms. Billingsley, I'd like to understand better does DPH have a process? And I will also ask this of Ms. Rogers and CHA. What is the process when hospitals are breaking the law in terms of not enforcing the staff-to-patient ratio?
As we discussed previously, and I'm disappointed to hear about the comments made, stated regarding the reaction of some of the surveyor staff in the district offices. That will certainly be clarified for them very, very promptly. I'm also disappointed in the fact that some of these are situations have been investigated, and they have been substantiated, and yet they appear to reoccur. And that is a trigger for us to conduct on-site investigations and revisits to confirm compliance. So again, I thank you for bringing this to our attention, and I encourage you to bring attention to matters like this in the future. But the important piece is we don't want to have to rely on that type of situation to solve what could be a problem. Everyone has said it is the law, whether we like it or we don't like it. I don't get to have an opinion. My job is to make sure that the mandate is followed, and I appreciated the opportunity that we had discussed earlier to look at how we can more proactively look at staff ratios. And I think this gives us an opportunity, again, to design a program to address this issue.
I will be interested, thank you, Ms. Billingsley, and I will be interested in receiving from DPH a memo on how you will, because this squarely falls on DPH in monitoring and monitoring the hospitals on these ratios. I think, of course, it's helpful. I like to understand what CHA is doing, and this is more of an advisory capacity on the ratios. And the accountability piece falls squarely on DPH, and I would like to see in writing an approach, because it sounds like, just like we have a high recidivism rate in our prisons, it sounds like we have a high recidivism rate in our hospitals on not complying with breaking the law on this point. Ms. Rogers, is there anything that you might be able to add to shed some light on this?
No, I would just say that we try hard every day, every shift, every hour to comply with the law. It's a difficult law. We know that we don't have enough registered nurses. Back to your point earlier, establishing competence for nurses before we put them on a unit. The experience in the emergency department, again, where we staff on historically how many patients are there. When an additional patient comes up that has an urgent need, morally and ethically as a nurse, I'll say in front of committee, I've broken the law because a patient needs care. So it's very challenging for us to do it. We try hard every day with every patient to comply.
Still a lot to say here. It's been a good hearing. Before we begin the public comment portion, and then I will be speaking after that portion, I'd like to recap what's been discussed so far. Ms. Billingsley, if you could remain at the witness table for just a few more minutes. The others, if you would like to be off the hot seat, that would be fine too. Ms. Billingsley, I want to thank you for your participation today and for being on the hot seat. So you've been a valuable asset to the department since you were appointed in July of 2006, and I know that quality improvement is as important to you as it is to me. With that said, I want to make sure that before we all leave this room today, we are on the same page with what we expect from the department moving forward. I would like to take a moment to review with you the things the department has committed to do and the timetable the department has committed to in each of the patient safety areas we've discussed today, being 3: hospital-acquired infections, adverse events, and nurse-to-patient staffing. I would also like to add a few things to the list that I think are supported by the testimony and information we've received today. I would like to have something in writing from the department that outlines and affirms these commitments no later than December 1st of this year, of 2010. As a preface to what I'm about to go through with you, one thing that would be very helpful is if the department could provide to the committee a list of any legal or other impediments, obstacles, it believes is impairing its ability to implement the hospital infection bills. It's distressing to hear that implementation is being held up by things that could be clarified through regulations or cleanup legislation, and we have to understand people are dying. An example is the problem we've heard about that the department lacks the authority to require hospitals to report the patient-specific data it needs to adjust the hospital infection data it receives from hospitals to allow accurate comparisons of hospitals. For each of these obstacles, it would be useful if the department could tell us whether the problem is something you can address on your own or own through regulation, or if it's an area where there needs to be additional statutory authority. So at this point, I would like to do public comment, and then, oh, wait a minute. Okay, this is where okay. Now it gets long here. Okay. I need to go through a recap here of some commitments and timelines, DPH commitments and timelines, just so we all understand the commitments that we've made, that the department, that we have made with each other here. Under hospital-acquired infections, in the area of surveying of hospitals for their compliance with hospital-acquired infection control measures, you've told us that the department is currently inspecting hospitals for compliance with all of the hospital infection control requirements as part of the routine inspection process. I would like to see that, please, in writing. In the area of training of hospital inspectors, you've told us that training in the new patient safety licensing survey has been provided to all staff involved in surveying hospitals. I would like to see the department commit to provide training on an ongoing basis, say within 6 months of the adoption of any new hospital infection control requirements or guidelines. Does that seem fair?
Yes, it does.
Thank you. The next one. In the area of hospitals reporting of rates of hospital-acquired infections, which is required by my SB 1058 of 2008, you've told us that you expect 100% of hospitals to be reporting. Well, are you telling us that 100% of hospitals will be reporting by November?
I would include this in our response and would respond earlier to that. I would need to check that 85-15% to determine where we are today and how far we are as in our timeline with cleaning up that gap to know that we could hit it by November.
But I would say that we will hope the percentage is larger than 85%. Yes. And frankly, that I will hold the department to the fire on getting to the 100%. It's just very important. I would like this in writing in terms of where you will be by November, including the steps the department is taking to ensure that hospitals enroll in the NHSN reporting system and share their data with DPH. A lot of what I will be asking for collaboration with whatever entity exists that can help you in assessing accurately what is going on with the hospital when it comes to any one of the three areas where we have really spent a large part of the afternoon. Also, in the area of hospital reporting of infection rates, I would like a commitment from the department on when it will issue guidance to hospitals on how to report surgical site infection data. Let me say that again.
No, I understand what you said.
When will you give guidance to hospitals on how to report the surgical?
Are you asking for us to, is the request to provide written guidance to California hospitals as to how they're to interpret 1058? Or is the our surgical site?
If you can.
And if you can't, tell us what clarification.
Right. If you can. And if you can't, tell us what is in the way of
what would
reporting.
be necessary?
Yeah.
Okay, yes.
So
okay.
help us help you. Help us help you. Help us help the public.
That's what I took away before. Thank you.
Great. Thank you. Okay. Next, on the regulations DPH was supposed to develop to implement current CDC recommendations for prevention of hospital-acquired infections from SB 739, 2006. You've told us that the department plans to start developing the regulations in February of 2011, which is quickly upon us. I would ask for a commitment from the department on when you will issue final regulations on this. So do you know, can you give us a commitment on when we will see the final regulations?
Right, we will go ahead and provide that in our response with respect to the timeline.
Fine, thank you. Okay, I would suggest by October 2011, since it's fairly well known what the guidelines are. So I hope that will be your response. And I note that you have not commented on my response, but that's the goal, okay?
Yes, we heard.
Thank you. On the public reporting of hospitals' influenza vaccination rates for hospital employees, I would ask the department to commit to a date by which this data will be posted.
Again, the data from the 0809 has been issued. 09-010 would be between now and the end of this year. And then the statute is written to require us to report 6 months after the influenza season. So we intended to abide by the statute with respect to this seasonal influenza season.
Okay, so for the 9-10 data between now and the end of the year?
Yes.
Fine, thank you. Okay. I would like you to the department to provide a list of all outstanding regulations required in the Center for Healthcare Quality and a timeline to have those regulations promulgated. So what's left to do? And when are we going to do it in terms of the promulgating the regulations? Okay.
Yes, we have that.
No, I mean, on the issues that we've talked about, obviously. I would like you to provide, the department to provide a list of hospitals that have, this is key here, that have not authorized DPH to use their rate of hospital-acquired infections.
Right, who have not granted us access to their data in NHSA.
I want to know who they are.
Yes.
The public wants to know who they are. I'd like the department, please, to provide its input in clarifications that may be needed to implement on the requirement to retest patients who show evidence of increased risk of invasive MRSA prior to discharge. That's the whole piece about, assessing where they were when they came in, assessing where they are when they leave, and any clarifications that are needed to implement the requirement. Is there anything fuzzy about, we want to know when a patient's admitted whether they have MRSA, and we want to know when they leave the hospital if they show evidence of increased risk of invasive MRSA. Okay?
Yes.
Thank you. Okay, that's on the first piece. Now we'll do the second part of the hearing on adverse events. You told us the department is finalizing a contract for someone to analyze the underreporting of adverse events, and you'll develop a plan of action to address that underreporting of adverse events. I would ask for a commitment on when the department will complete this analysis and when it will develop a plan of action. My suggestion would be June of 2011, since it should not be shocking that we're wanting to know this information. That's.
If there's anything different than the 2011 June date, I would let you know and give you a timeline as to why.
Thank you. I would like the department to provide me with what the department is doing to increase the number of adverse investigations on time. Does telemedicine play a role in this event? We spent probably more time in this area than anything else, so what I would like is the department to provide me and us with written information as to how you're going to increase doing these investigations of adverse events in a timely fashion is the main part of the question.
Yes.
And then also, can telemedicine play a role in this? If you could address that also, please. Next, please indicate, have the department please indicate what checklists, spent a lot of time on this one too, what checklists are required to be used to reduce the incidence of adverse events. And I'd like this information to be finite enough to really differentiate between something that's recommended to be done and something that is mandatory that will be done. It's only by knowing the difference can we actually figure out what step we must take to seeing that every single hospital has a minimum. I mean, hospitals can go way beyond that, but a minimum number of things that need to be on the checklist. Third area under here, administrative penalties. You told us that DPH plans to commence developing regulations to refine its authority to levy administrative penalties for patient safety and other licensing violations in November 2010, and expects to have final regulations in place by late 2012. I would ask the department to consider moving this up by at least 6 months. Well, the one is quickly upon us here, but where it says to have final regulations in place by late 2012, pardon me?
Over a year and a half to get to final regs.
Yeah, we need to have a shorter time frame there. A year and a half is really, I think, too long to get to the regs.
We also needed them for the breach language, as you know, we're involved in that situation as well. So we're working on the administrative penalties and the breaches pretty close to the same time frame. So we'll look at that timeline again.
Okay, thank you. And if you can address it in the paper you will send, and your thinking of how you might be able to do that. Okay, additional authority. This next area is called additional authority and tools for enforcement. I would ask the department in its response to respond and comment on the following suggested changes or enhancements of the patient safety bills, many of which have been touched on today. First, require DPH to develop a survey tool to inspect hospitals for compliance with hospital-acquired infection requirements, and to update it within 6 months of adoption of any new infection control requirement or guideline. Please tell me if I'm not being clear on any of these.
I'm sorry, I guess I may be getting tired.
Understand. Okay.
Could you clarify that
I'll
for
say it
me?
again. Sure.
Okay.
Requiring DPH to develop a survey tool to inspect hospitals for compliance with hospital-acquired infection requirements. That's the first part.
Yeah, and that's what we're doing now with the patient safety
Right.
licensing survey.
And to update it within 6 months of the adoption of any new control requirements.
I remember now. So any new,
So as new things
any
pop
new
up-
mandate,
Right.
would need to be included in that survey
We want them
tool
quickly-
within 6 months.
Right.
training.
And the training also.
And the training. Okay.
Right.
So add to the survey plus training.
Thank you. Okay, next. Require hospitals to provide patient information needed to allow DPH to adjust hospital infection data, which will allow for meaningful comparisons among hospitals. This is where we want the hospitals to report that information to you. We want you to proactively, on the, if there are 40 or 60 hospitals that are not reporting, we want to see that you proactively are getting the information.
Yes.
It's like when as you know, I also do a lot on seismic safety, and it relates to what I'm going to say, and I know we're getting tired, so I'll be somewhat brief, but there have been some hospitals that have sent in a report with nothing on the sheet, but they sent in the paper. So did they comply with reporting requirements? No. They sent in the piece of paper that was blank, but they didn't put on the piece of paper, we have done nothing in this area. So at that point, you need to be proactive and get that information from them. Okay. Impose specific penalties for hospitals that fail to report on their hospital infection control procedures and infection rates.
Yes.
Yes. Require hospitals to authorize DPH to access hospital infection data that is reported to HNSN. This is...
say again on that
Sure.
one.
Require the hospitals to authorize DPH to access the hospital information data that is reported to the HNSN.
Oh, right. Require them to grant access to the information.
To grant
Okay,
access so you can use the information so that you can use it to implement regulations, to do oversight.
So that would
and
be
so that the
something
public
as a
understands.
proposal that we would send back as part of our
Right.
proposed changes.
Right. Next one. Require hospitals to report surgical site infections for categories of surgeries as well as for specific procedures. So for categories as well as specific procedures, what I'm looking for there is a combination of neither just the specific approach or the generic, the composite approach, but I'd like to see both because we will gather information that way. Okay. Next one, impose specific penalties for hospitals that don't report their implementation of CDC recommended procedures to prevent hospital infections. What I'm getting at there is that the CDC procedures are recommended. They're not mandatory, but it's important to understand whether they've implemented those recommended procedures to prevent hospital infections, or whether they have not implemented them. And if you look at that category, that domain, are they the same hospitals that are just not doing X, Y, Z? And, then proactively some things that need to be done. The next one. Clarify that DPH can use hospital licensing fees for costs of the hospital-acquired infection program and committee. We want to be sure that you have can use the fees for those costs.
Currently,
for those ongoing costs.
Right.
So
yes.
you have the money.
At the reduction of the ERA funding is really what you're looking at, and so could, in essence, we would have to be given position authority, of course, but if we use the fees now to support the HAI program.
But to clarify that you can, because earlier I think you may have said that you didn't know if you could always use it that way. And we want you to clarify that you can so that you have that source of money.
Certainly.
Okay, thank you. Next, limit the size of the appointees to the Hospital Acquired Infection Advisory Committee to 12 and provide a balance between hospital and consumer representatives.
We'll need some clarity on that one regarding the composition.
Okay, so this is so far the only one that you want to talk.
Pardon me? Well, we'll have to go back and look at what's in statute now and compare that to what you're asking.
Okay, thank you. The next one, require DPH to work with OSHPD to analyze hospital discharge data on an ongoing basis to identify hospitals with potentially high rates of infections and adverse events. Okay, yes. Next. Inspect hospitals for compliance with nurse-to-patient ratios as a part of routine inspections.
Yes, we have that down to create a more proactive process.
Yes, proactive and routine process. Thank you. So you will do that?
Yes.
Okay, thank you. Require a timeline for when the new survey tool will be used in all hospitals.
Yes.
Thank you. Next, commitment by the department that the department will more proactively and routinely check to see if hospitals are, well, that's it, routinely, what I said before, proactively and routinely checking to see that hospitals meet the staff-to-ratio requirements. Okay, you said yes to that before.
Yes.
Thank you. Okay, next we have a couple people under public comment, and then my closing remarks will be limited to 92.5 seconds. So first we have two people who wish to testify, Shannon Oriola and Martha Swaim, I hope I pronounced that correctly. If you both could come up, please. And if you could each limit your comments to 2 minutes each, and thank you for staying.
Thank you for...
And if you could identify yourself, please.
My name is Shannon Oriola. I'm the president-elect of the California APIC Coordinating Council.
And APIC is?
Pardon?
And APIC is?
APIC is the Association for Professionals in Infection Control and Epidemiology. So I'm representing the 700-plus infection preventionists in the state of California. Thank you very much for allowing us to provide testimony. A lot has been said, so I'll skip some of the fluffy introductories for the sake of time. I did want to make a few brief points. One is CAC firmly believes in mandatory healthcare worker vaccination and feels that that would move the compliance of healthcare worker vaccination to the 98% or above with that, and would consider the department looking into that. CAC asked for clarification of the MRSA testing requirement for inborn infants. The Healthcare Associated Infection Advisory Committee listened to Dr. John Bradley at the last meeting, and the committee voted to recommend to the department and to the legislation to consider looking at the interpretation of testing the inborns transferred to an NICU. For example, and you have in front of you Dr. Raymond Chin's testimony as well, who represents Mary Birch Hospital for Women and Newborns, delivers the most babies in California hospitals, and tested over 1,000 infants with no positive MRSA results. And he discusses the potential harm of testing infants for MRSA, potential bleeding and trauma, reduction in breathing and heartbeat, for example. So the committee did recommend to look at that. So they're at harm. I would consider you looking at his testimony. There were no positive results, and hospitals are required to have a risk assessment for multi-drug resistant organisms to look at MRSA and other resistant pathogens. There was there was publication in JAMA to show that there is a decrease, so hospitals have done some work. We support the transparency and reporting, the MRSA screening requirements. However, we'd like you to look at the infant screening, if you could, please. Finally, to look at mandatory infection staffing ratios. I know we've looked at that in the legislation in the past. There's been over 40 regulations, mandates, CDC guidance, Joint Commission standards, with no change in the legislation. I think right now it's 200, one full-time equivalent infection preventionist for 200-plus beds or more. So we need to kind of update that a little bit. Those were my comments. I thank the committee for your time and listening to our testimony. Again, we are very passionate and share your concerns. Thank you.
Is this microphone on? There we go. Okay, can you hear me? Good afternoon. Thank you. My name is Martha Swaim, and I'm here on behalf of my mother, Neva Swaim, who had hip surgery in a hospital in 2009 and died 2 months later in a nursing home. She suffered from at least 7 infections, including UTI, atelectasis, bronchitis, C. diff, MRSA, candida, and esophagitis. She also had pressure sores. And she was starved, dehydrated, overdosed on an iron supplement, and suffered from bruises and abrasions from an unreported fall. During this time, I did observe staffing shortages in the nursing home, and this was confirmed by some of the people who work there. Many of the problems were not addressed in a satisfactory manner, in part because records were inaccurate and incomplete. For instance, it was a stated policy of the nursing home to never log less than 25% consumption of a meal, even if a patient consumed less than 1%. So while 2 speech therapists and I observed that Mom was not eating, the nursing home continued to insist that Mom was eating 50% or more of her food, including the same meals reported by me and by the speech therapists. The same thing occurred with Mom's physical therapy. Staff insisted Mom was receiving physical therapy right up until the moment the head nurse came into Mom's room and announced that Mom was dead weight. Mom was unable to defend herself because she was hard of hearing, and staff routinely left her hearing aids on the med cart and then assumed that Mom had dementia. As Mom's healthcare power of attorney, I was denied any requests for written records and was finally told I would receive them after Mom was discharged. I tried to move Mom to another nursing home, but the other facilities never received the faxed information they required. One facility sent a nurse to evaluate Mom and never received answers to her questions. After telling the state health department some of my concerns, I was told to call 911 and get Mom out. The nursing home first turned away the ambulance and then tried to turn away a gurney van sent by the hospital. Mom finally arrived at the hospital, but I was told that it was too late. I paid to get copies of Mom's files after she died and received some records, but some are missing. I originally tried to get those records because I wanted to inform my mom's care going forward. I was getting contradictory information about her condition and treatment and wanted accurate information. Now my only hope is that this experience and my cries for help may inform and improve others' care going forward.
Martha, I'm very sorry, not only for your loss, but for the way she died.
Thank you.
And it was preventable. Thank you for sitting through this hearing and for saying what you did, because your mom is one reason I'm holding the hearing.
Well, I really appreciate everything you're doing. Thank you.
Thank you.
And you chair the subcommittee on aging.
Pardon me?
You chair the subcommittee on aging as well.
Right. And Peter reminds me I chair the subcommittee on aging and long-term care as well as the Senate Health Committee. Briefly, it's been a long hearing. I think a very productive one. Ms. Billingsley, I really, in particular, want to thank you for being on the hot spot for so long today. And I'm sure the department understands where we need to go, and positive marks for the good things that have been done, but the road is still very long and very wide, and it's time. It is certainly time that we create this accountability. I'd like to thank all the panelists, the reactor panelists. I'd like to thank my committee staff. And in closing, I would just say, you know, we're doing this to help people who, for the most part, won't be able to help themselves. There are cases where that's not the case, but, you know, it's one thing in life when a person, we never want to see anybody die, and I certainly, you know, my parents, my yaya, my grandmother, my favorite person in the world, my late husband, Al Alquist. There are deaths from cancer and heart disease, and then there are what I call really preventable deaths. We really can do something, and if all the people were lined up around this building, they would take up all of Sacramento of people who died over many years, because we're talking about it more now, but who died from things that were preventable. And, you know, it's really up to us. And so in closing, I would just say it's really time, and we need to fix the problem and save lives. So thank you very much. Ms. Billingsley?
Yes, I just have one question. I think we have a large, significant number of items to address going forward. And in order to be able to do so, I was wondering if you or your staff could provide us written list of what we need to do.
Certainly.
We really want to make sure that we do everything thoroughly and that we don't miss the mark on anything, because these are pretty comprehensive. We want to, and again, I can only restate the fact that I think we're all in alignment. We're all here for the same reason, and we want to make sure that we do the best job possible. Thank you again for having us.
We will be happy to do that. Thank you very much.
Thank you.
Thank you for being here. Meeting adjourned.